Thank you.
Afternoon, everyone, and it's my honor to introduce our first presenter today for our best practice training and opening session. And it is with the National Association of County Behavioral Health and Developmental Disability Directors. And we're happy to have Jonah with us today. ACLI and members of ACLI have a long-standing relationship with NACFID. And for those of you who are new, we do have some new people here just to let you know what NACFID is about. It is the national voice for county and local behavioral health and developmental disability authorities. NACFID provides education, policy analysis, and advocacy, promoting national policy for mental health, addiction, and developmental disabilities. NACFID is an affiliate with NACO, the National Association of Counties, and that's important to us in our work because, again, we are county representatives in our work. And NARM, which is the National Association of Rural Mental Health, is an affiliate of NACFID, important to the ACLI membership, also representing counties and rural areas. And so I'd like to welcome Jonah again. And Jonah, just a little bit about him. Jonah Cunningham currently serves as the president and CEO of the National Association of County Behavioral Health and Developmental Disability Directors. In this role, he proactively advocates for national policies that recognize and support the critical role counties play in caring for people affected by mental illness, addiction, and developmental disabilities. In this capacity, he serves as executive director of the National Association of Rural Mental Health as well. Prior to joining NACFID, Jonah worked at Trust for America's Health, a public health think tank, where he focused extensively on ways to reduce mortality from substance misuse and suicide. Additionally, he worked as a congressional staffer for several years in the office of Congresswoman Grace F. Napierton. I'm sure I messed that up. Where he helped to reestablish the Congressional Mental Health Caucus and created a suicide prevention task force within the caucus. Jonah Cunningham has received numerous awards and recognition for his commitment to the field of behavioral health and those served by the nation's behavioral health system. Jonah has a Bachelor's of Science in Political Science from the University of Utah and a Master's of Public Policy from the George Washington University. In his free time, he enjoys learning how to cook and is an avid Jiu-Jitsu practitioner. All right, I got you. Thank you.
Thank you. Thank you for the kind introduction, making me sound much cooler than I actually am. Very excited to be here. I have to start off with a dad joke. I flew in last night. Boy, are my arms tired. Thank you. We're firing on all cylinders. So I wanted to give an update on federal policy. Let's forward back. And Deborah already mentioned a lot of the background. NACFID, established in 1989, is the voice of local authorities in Washington, D.C. Thinking of it like Russian nesting dolls, where NACFID is an affiliate of NACO, the National Association of Counties. And by the way, if I say an acronym and I don't explain it, I owe you a cup of coffee. It's alphabet soup in DC, so I have to really check myself and be good on that. We have a dual focus of IDD and behavioral health, so very different. Some overlaps quite a bit, but very different structures as well. Similarly, the National Association for Rural Mental Health, or NARM, includes a spectrum of members. So it's policymakers, advocates, academics. Since 1977, when this organization was established in Madison, Wisconsin. We also publish a journal for rural mental health with our friends at the American Psychological Association, and that Russian nesting doll, NACO, NACFID, NARM is an affiliate of NACFID, so they receive some benefits of NACFID membership. So before starting off with an update, I always like to start with context, so we can kind of shake off the rust from our high school civics class. There are obviously 3 branches of government. Everyone knows this. Please don't fall asleep yet. Don't fall asleep yet. But why I mention this is because these things aren't static. There's often tension between the legislative branch that passes legislation or doesn't, the executive branch that then implements it or goes a little step further and publishes rules and tries to do things that maybe there's no statute allowing them to do so. And the judiciary branch that may call balls or strikes, may override a congressional action, may make Medicaid expansion optional, for example. So again, these things aren't static, and politics do come into place when it comes to policy. So if Congress is controlled by one party and the executive branch is controlled by the other party, there might be more tension. Now, I know. I joke I'm mostly scar tissue by how many years I've spent in DC. So, but if we look at, well, blocking the first one, but basically the role of the federal government. Thanks, Joey. The role of the federal government when it comes to behavioral health falls under 6 categories. The first is research, which you'll see. And the federal government funds the National Institute of Health. Underneath that is the National Institute of Mental Health. They look at the biomechanics for serious mental illness, suicide, and fund a lot of research. Also, the Department of Defense engages in research on TBI or traumatic brain injury. No coffee yet, right? Additionally, the federal government also provides a lot of funding for behavioral health. You have Medicaid, which is the #1 payer for behavioral health services. And then you also have the block grants administered by the Substance Abuse Mental Health Services Administration, or SAMHSA. Yeah, sure.
I'm calling coffee because earlier you said I need to.
Okay. We got one. I do not want to break the. So besides funding, Lynn's Coffee Habit and the federal government funding behavioral health, they also provide technical assistance and training. SAMHSA, or the Substance Abuse Mental Health Services Administration, I said that once earlier, has a number of technical assistance centers. There's the Addiction Technology Transfer Center, the Mental Health Technology Transfer Center. They publish best practices, they do webinars, they do policy academies to really train up providers, and also they fund mental health first aid programs to train up laymen. Of course, the federal government also provides the rules of the road through regulation and oversight. They engage in a lot of surveillance, notably SAMHSA, which I've already said the acronym for, does the National Survey on Drug Use and Health, or the NISDA, which provides a lot of insight on provision of services or provision of services. The Centers for Disease Control and Prevention, or CDC, also engages in a lot of surveillance, mortality, the provisional numbers for overdose, for suicide, as well as actually we'll get into that new surveillance here in a minute. And then lastly, the federal government also provides services for a certain population. Now think of the Department of Veteran Affairs, and also our service members get direct services from the federal government. So now that we have that covered, let's look into key congressional committees. So looking at the legislative branch, if one thing you take away about Congress, they have one job every year, and sometimes they make it complicated. We'll talk about that too later. But their one job is to pass an appropriations bill for the fiscal year ahead. So this fund keeps all the lights on, and this is packaged in 12 different appropriations bills. Relevant to behavioral health, this would be part of the labor HHS bill, or Health and Human Services Department bill. Now, because it's Congress, they have to pass the appropriations through the Appropriations Committee. But there's also authorizing committees that create accounts. They allow for certain action within the agencies. So looking on the Senate side, there's the Senate Finance Committee, which has broad jurisdiction over Medicare and Medicaid. You also have the Senate Health Committee, which says right in your name, over health, education, labor, and pensions. But relevant to behavioral health, they have oversight of the Public Health Service Act, or the act that established SAMHSA and CDC. I said those acronyms earlier. On the flip side, you have the sister committee to the Senate Finance Committee, which is the Ways and Means Committee, oversight over Medicare and Medicaid. And lastly, you have the Energy and Commerce Committee, which has the broadest jurisdiction in Congress, with one former committee chairman, John Deagle, saying, if it moves, it's energy. If it doesn't, it's commerce. So it's not just public health service, not just behavioral health. It's tech, it's IT, and some environmental health regulations as well. Very broad, very important committee. So let's shift from from Congress to the executive branch. And of course, I wanted to highlight some key agencies under Health and Human Services, but that doesn't denigrate the role that Housing and Urban Development, Department of Housing and Urban Development plays, Department of Labor, which regulates parity, mental health parity, Department of Defense, Department of VA, all the other important departments. But for behavioral health and HHS, obviously some of the key committees, or key agencies rather, the Center for Medicare and Medicaid Services, the bulk of funding goes to them. The Substance Abuse Mental Health Services Administration, they handle not only the block grants, but some of the CCDHC planning grants, the health. Oh, okay, I need to say that.
Same person.
It's good. It's teaching me. It's positive reinforcement. There's also the Health Resources and Services Administration, or HRSA. Now they do the National Health Service Corps. They look after workforce. They do a lot of rural health work as well. You have the National Institute of Mental Health. I already mentioned a lot of the research they do, or NIMH. And then of course, the Centers for Disease Control and Prevention, or CDC, is somewhat of a newer player, especially the behavioral health realm. And the last 5 years, they've gotten funding, a significant amount of funding to do, first it was opioid prevention, now it's overdose prevention, and allow for the whole spectrum of substances. But they also have some funding for suicide prevention, as well as, interesting enough, adverse childhood experiences, or ACEs work. So keep an eye on that, don't sleep on CDC. So we have the background, we shook off the rust from our civics classes, right? So let's look at some current challenges we're facing. So prior to COVID, there were accelerated rates of substance use, suicide, and alcohol-related deaths. I think between 2015 and 2017, something interesting happened, really horrific happened. Life expectancy for Americans went down 3 successive years. The last time that happened was 1917, and of course that was World War I and the influenza pandemic, which we have learned all too well what a pandemic is in more recent years. Between 2015 and 2017, the drivers were substance use, suicide, and alcohol. Now these deaths continue to increase year after year. Suicide went down between 2019 and 2020, but increased in 2021, the most recent data that we have. Now, because of increased substance use, also destigmatization, I think cultural norms are slowly changing in regards to health-seeking behavior and the acceptability at least of behavioral health services. There's an increased demand for substance use and mental health services. And of course, there's an increased demand on providers, and there's a lot of burnout of providers and also a lack of workforce. Now, general challenges that the system is facing is first and foremost sustainable funding. Making sure that we're rating and blending funds. It's been, I'm speaking to the choir when it comes to funding. Also, the need for access, and also that goes hand in hand with workforce. And of course, coordination with other sectors, whether public safety, education, housing, and social services. So the federal government tried to address some of this with their federal response to COVID-19. What they did, and this you can kind of impress your friends if you want to. So supplemental appropriations is an appropriations bill passed outside of regular order, outside of the regular continuing, rather outside of the fiscal year. There were 2 supplemental appropriations bills for COVID, the CARES Act and the American Rescue Plan Act. A lot of that had behavioral health problems. In effect, it basically doubled SAMHSA's budget. There's a massive increase in block grant, one-time money with flexibility on spending it down. There's also new funding. For example, there was $30 million for harm reduction that was passed. First ever harm reduction funding from the federal government to go to things like fentanyl test strips and syringe service exchanges. There's also treatment flexibility, the initiation of audio-only treatment. There was increased coordination amongst agencies, and of course, surveillance. CDC established the COVID experiences panel, as well as coordination with SAMHSA on the behavioral health ramifications. So we got the past, we have our basics. Let's go to what's happening in the last couple of years. Now, I know that this might not come to any to people, but it is the high watermark for behavioral health when it comes to Congress, the attention. Hopefully it leads to more action. first and foremost, this year, the president released a mental health plan, the first president in decades to talk about mental health, the need for behavioral health services in a State of the Union address earlier this year. We also have the Surgeon General issuing a general advisory on youth mental health and work and burnout of healthcare workforce recently. And of course, the summary had the launch of 988, and we'll talk a lot more about that in a moment, and the build-up of crisis coordination. Now, executive efforts, obviously, there's kind of this tail, this ripple effect where Congress passes a bill, the money doesn't immediately go out the door. They have to establish, NOFOs, notification of funding opportunities. Thank you. I saw something kind about raise. So sometimes it takes months for once a bill is passed for the money to get out the door. And then of course the ripple effect continues to go down into the communities. There's also efforts to coordinate agencies. There's a behavioral health coordinating committee that was established, and that's in addition to a lot of other coordinating committees. My favorite being ISMIC, the Interdepartmental Serious Mental Illness Coordinating Committee. I know, alphabet soup. I wish I got paid by the letter. And they also shared a lot of 988 resources. SAMHSA, the Supplemental Mental Health Services Administration, and the State Mental Health Program Directors Association, or NASHPID, published a number of playbooks when it comes to 988 implementation. SAMHSA even went so far as to establish a page on their website listing all the 988 call centers with links in hopes of soliciting people to apply to work there. Now, in Congress, there's been a lot of milestones. This summer, there was the expansion of the Certified Community Behavioral Health Clinics, or CTBHC demonstration grant. And this was part of the Bipartisan Safer Communities Act, kind of an odd marriage, something that I know a lot of behavioral health advocates are uncomfortable with, getting tied to gun violence. With that expansion, it will be 10 additional states. So currently there are 10 in the Medicaid demonstration program, which allows for a prospective payment system. After 2 years, so starting in 2024, 10 additional states can apply. And then every 2 years, 10 additional states can apply. So 8 years total, we can hypothetically have all 50 states be part of that Medicaid demo. Now, there's also a huge windfall for 988 and technical assistance. I already mentioned the playbooks, but there's over 200 million that was just for basic setup of 988 technology investments, workforce recruitment, the whole bit. But again, that's oftentimes one-time money. And I will say, a bright note is that there's been a bipartisan focus on behavioral health. They can disagree on a lot of things, even the color of the sky. But behavioral health seems to be getting more and more bipartisan attention. We'll talk about that and more in a moment. Now, I mentioned Congress's one job every year, right? And that's to pass an appropriations bill. They passed a continuing resolution, which basically kicks the can down the road. Congress, like me in high school, likes to wait to the last possible minute to do it. Much my mom should do, bless her heart. So right now, funding is due to run out on December 16th. So there's talk about doing what's called an omnibus bill to continue funding through September 2023 to finish out the rest of the fiscal year and have new funding levels. A CR in comparison would just have the flat funding, what was previously authorized, which creates some difficulty, of course, in an inflationary environment that we live in. So there's that. In addition, yes.
What's a CR?
He's not. He didn't.
Oh, he did? I didn't.
Okay.
Never mind. Never
You
mind.
keep me on my toes. I'm going to regret this. So the House passed a bill to reauthorize some of SAMHSA's programs, including the block grants, raising the amount or the top line amount that the account is open for, if that makes sense. Think of it like me asking my mom to go if I can buy a bike. That's authorizing if my mom says yes, and then I go to my dad, who's the appropriator, and he gives me money. So authorization is not equal appropriation. The House passed this, and they also would establish a crisis coordination center at SAMHSA for 988. It's in the Senate, it's still being deliberated on. Additionally, going back to that bipartisan focus, the Senate Finance Committee has done a lot of work and has done, I mean, a lot of groundbreaking work that hopefully gets through the finish line. So backing up, late last year, the Senate Finance Committee released an RFI, a request for information, asking stakeholders to talk about gaps in behavioral health care. From that RFI, they then issued a report earlier this year and established 5 working groups focused on youth, see if I can get them all, youth, telehealth, parity, workforce, and integration. Now, these are bipartisan work groups. And these work groups also released discussion drafts or pieces of legislation. Now, these are out there for the public. But the debate is whether they can be attached to the end of the year package. Sometimes Congress, because of timing, there are very few things that can pass. And the last train out of the station seems to be this omnibus bill on December 16th. So, little side note, we can talk about advocacy here in a little bit, but that would be one ask. Now we can go in depth about the Senate Finance Committee proposals, just a little bit. So the first one, the telehealth, would remove the Medicare in-person requirement for telemental health services. It would also preserve audio-only coverage in Medicare and would direct Medicare and Medicaid to support provider use of telehealth. Critical for those in rural areas. We've also pushed for expansion of rural broadband as well, since not every community has access to telehealth. The second proposal, Senate Finance Youth proposal, some of these elements were included in that bipartisan Safer Communities Act that passed, I already said CCBHC this summer. I know, sorry. And particularly the TA Center at CMS, the Center for Medicare and Medicaid Services. Now I'm on my toes. But for school-based services. But the other provisions include a streamlining of enrollment of out-of-state providers for Medicaid, would allow same-day Medicaid reimbursement for physical and behavioral health care. So again, great piece there. The next two are something that really piqued my interest. First and foremost, workforce. So it would increase the number of psychiatry residents by 400. It would also cover marriage and family therapists under Medicare. There were some increased flexibilities under CMS's 2023 payment schedule, where it's not direct supervision that MFTs can practice under Part B, but rather general supervision. That's flexibility, I guess. The one piece for this proposal that caught my interest, but it would create a new workforce demonstration program under Medicaid with an enhanced FMAP for states to engage in workforce recruitment and retention activities. So increased funding and hopefully increased flexibility there. This next piece, the integration piece, really focuses on crisis response. My critique of 988, I will openly say, is, sometimes it's still the dreams policy on the federal level where they pass 988 and they're like, oh no, we got to get the resources. We built it, the resources have to come now. And we've seen it pieced together in the past about 988, we have the lifeline funding, that's at SAMHSA. And the American Rescue Plan Act earlier this year, it just went live. Oregon was the first recipient. There's a 5-year Medicaid demonstration program for crisis response. And then on the tail end for crisis stabilization, CCBHC seemed to be kind of the framework a lot of people work with. But for this proposal, they also talk about Medicare quite a bit. Create standardized payment for mobile crisis response team, but also make that crisis intervention program, that pilot, a permanent state option rather than just 5 years. It would create bundled payments for stabilization services. It would establish a TA center at CMS for behavioral health integration, technical assistance center. And then also would establish direct CMS to establish best practices for crisis continuum and provide funding for TA and planning grants. So we've gone through 4 of the 5, right? We've gone through youth, telehealth, integration, and workforce. Now the 5th one, focused on parity, hasn't been released. At the end of this year, the 117th Congress is done. That means all these pieces of legislation that have been introduced turn into pumpkins, basically. They have to be reintroduced next Congress. So we'll see what happens. Again, December 16th, it's really crunch time. Now, looking past the 117th Congress and the new Congress, starting in January, there are still some long-term challenges in behavioral health care or behavioral health faces. First and foremost is workforce. Reimagining, retaining, retraining, and also reevaluating our workforce. There's a lot of different reports that have been out there. I think even on the federal level, there's a little bit of a disagreement or misconception of what the workforce challenges are. For example, I'm going to butcher the numbers, but it's the magnitude of 10. HRSA says there's not going to be a workforce shortage in 2030 in the most recent report. I'll send it to you. SAMHSA says that we have a workforce shortage of 2 million. I'm no math major, it's bizarre. But of course, SAMHSA does not have any workforce programs or grant programs, while HRSA does. So there's some tension there. I said that earlier.
Just, I know we put Dee Dee over, in a corner a lot of times, but prior to the pandemic, there was some evidence, maybe from Optum, of like the direct support professional workforce shortage. It was predicted to be around 700,000 positions. And then during the pandemic, we lost so much more capacity in that area. So I guess because Dee Dee is kind of a small number of people, but a larger number of money, it wouldn't appear right in these data, but I haven't heard any updated numbers of the projected shortfall.
For direct support professionals or DSPs. The issue, one issue with that, it's something that we've signed on and supported as a piece of legislation, is that there's no occupational classification code, which don't fall asleep yet. It is, that sounds very dull, but the Department of Labor has classification codes to track workforce participation for certain industries and professionals. And unfortunately, DSPs don't fall under one.
So this is why.
That's one issue. Additionally, the third proposed supplemental appropriations bill, the Build Back Better Act, if you recall, RIP, had a massive amount of funding for home and community-based services, but that was.
But it's still, that would have accomplished about 10 years of increased federal match, which some were saying that's not good enough. Yeah.
Yeah.
Okay.
Moving on from workforce, there's also, I say 98 implementation, but I think there's going to be a long-term challenge building out crisis continuum. The framework on the federal government being someone to call, someone to respond, somewhere safe to go. And coordination between all the sectors that are involved: public safety, healthcare, even education, housing, social services. On a similar note, there's also the expanding behavioral health continuum, where we talked about expansion of CCBHCs and the crisis continuum, but even looking further than that, there's a movement towards trauma-informed care for a number of years, adverse childhood experiences on the front end, and what we can do prevention-wise before people are in crisis. And then on the tail end, looking past CCBHCs, what are long-term services, or lifting perhaps the Institute of Mental Disease of the IND exclusion, which limits CMS's ability to reimburse that facilities with more than 16 inpatient beds. All of this is not possible without funding. I think our brothers and sisters and non-binary friends in public health know all too well the boom and bust cycle of funding, where COVID happens, they get a ton of funding and it slowly cuts away, like they did in Ebola and other things. Obviously, the funding streams are different for public health than they are for behavioral health, but I think it's a cycle that we need to be cognizant of. We got a lot of one-time funding that can be extended through 2020, be spent through 2025, but we have to look long-term at how we build out our systems. And that also requires coordination at several levels, both not only in your community, but from the state, local, and federal levels. Now, I'm a big believer in not just doing info dumps, but also giving people tools to impact policy, also kind of like the whole civics education piece. Working in a congressional office, I've seen the impact that constituents can have, where if they call, they flag a piece of legislation, like, why aren't you on it? You didn't know, that's a good point, you should be on it. We have no defense. You can impact policy as well. So one framework I like to have in the back of my head, or one saying I have in the back of my head, it's actually above my computer, so Bruce Lee is just staring at me all day. I think of it kind of a moral imperative, like knowing's not enough, we must apply, willing's not enough, we must do. I am open in my disdain of thought leadership. I think this should be action leadership. So with that being said, one framework I like to say for advocacy, or one thing to keep in mind when you're talking to policymakers, whether it's on the local level, your mayor, your supervisor, federal level, your congressman, your senator, is head, heart, and feet. And what do I mean by that? Not in a weird way. Don't like try to braid their hair or anything like that. But when you're talking, trying to reach their head, you're talking about logic, statistics, impact, right? You have a study, you have statistics that you can point to about the impact that behavioral health has, or the short gaps, or the gaps that have long existed for healthcare. Heart can preach about empathy. You can talk about right or wrong. You can talk about values, sometimes emotional appeals, right? There's the logos, pathos. And all of that is great. I think both of those are excellent points, but they're all for naught if you don't reach their feet. You don't tell them what direction you want them to go. And, Rome wasn't built in a day. I'm not telling you to solve behavioral health, but think about an action that you want. It could be as simple as I just want to build a relationship with this person. So I'll send them an email. And side note, as a congressional staffer, you'd be surprised how many people I give my card to. And I'm like, please send me the details. I want to know about the study. I want to know about this impact, this program you're doing locally. And I could count on maybe one hand the people that would respond, the people that would proactively reach out to act as a resource. And I know there are demands in everyone's time, so I'm not trying to begrudge that to anybody. But going above and beyond and thinking about what you want from that meeting. And part of that is also knowing the systems in play, the systems involved, knowing that Congress has one job every year, the appropriations process, and that must-pass bill is a vehicle to pass behavioral health legislation to strengthen the workforce or to promote integration. And always thinking about next steps and knowing that policy isn't an overnight thing. It takes years, it takes decades, it's painstaking, it's frustratingly slow, but we have to keep doing it. We have to keep pushing forward. That's the type of society we're in. We want progress. So head, heart, and feet. With that, I think I might be at time. I hope we have time. Okay, questions, and also any acronyms I missed. But here's my email. Please, we have a great relationship with, I'm not going to try to say the acronym and butcher it. ACMI. I was going to say ACME, that's like no.
What's ACME?
The Association of Community Mental Health Authorities of Illinois. I did my research, so. Yes.
So if I'm not in the field and I'm not doing this work, and I heard your presentation, and what I might have just heard is that the lot federal money going on. And so as I digest that, how might you explain how that either complements or replaces the need for local funds?
It's a good question. So part of it is, there's looking at the funding streams and the purposes of those funds, right? I mentioned the enhanced FMAP, the federal match allocation. I'm butchering the P, but no one copy on that, but that's through Medicaid, right? The state still has to do a match for Medicaid, roughly, over 50% is paid by the federal government, but there's ways to enhance that. I don't think traditionally the federal government has left to the states the authority for behavioral health. They try to supplement it through the block grants. I would argue a lot of it's one-time funding, and that's going to dry up pretty quick. And if we're looking at sustainable funding streams, it's not just the next 5 years, it's the next decade or 2 decades. How do we build a workforce? How do we build systems and structures or even buildings to make sure that we're getting people connected to care? And a lot of that's going to be locally led and state led, despite, some of the, what we say in the Beltway with 988, it's the federal government can do as much technical assistance they can, but inherently it's going to be a locally led effort. So hopefully that wasn't too roundabout an explanation.
Chat and see her question out.
Hopefully it's no one calling me out on an acronym.
On the audio.
Oh,
That's a while.
Yeah, that was before when I was trying to log on.
right, you can't see.
I finally got through.
You
Yeah.
can't see.
Okay. Maybe we turn it up.
Any other?
I have a question. I'm sorry to, like, if I'm butting into, so when you were talking about the resolution that ends December 16th, I think that, when did they vote on that one? Because that's when we were making a major push for a couple of requests through NACDA and NACO for, one was the IMD exclusion related to substance use, going from 30 to 45 days. So I'm assuming that's failed.
That failed.
And then the other one was the one with a really big, it's a big ticket item across the country, how much money counties lose because of people who are in jail, especially those who are pre-adjudicated, and their health and behavioral health care costs can't be picked up by Medicaid. It's like $40 billion across the country, so that failed too, huh?
Yeah, PMA exclusion.
This is so critically important. When do you think, once we get back to January,
I mean,
just pick it up?
the hope is advocacy, it all gets attached to that December 16th piece. And going back, it could, going back to what a CR, continuing resolution, besides flat funding, there's also sometimes they'll attach anomalies or certain accounts will get increased funding, like funding for Ukrainian assistance or COVID funding. Last year with the CR, there was an anomaly for 988. Unfortunately, the one that was passed, again, the end of the fiscal year is September 30th. Some people indeed, some real stories, some people indeed have fiscal New Year's youth parties. We're a very dull bunch. But those were included. But what they did September 30th was kick the can through December 16th.
Okay, so
Could happen.
still, even with that high price tag.
I mean, if I was speculating, and again, this is all speculation and conjecture. The Medicaid inmate piece has a better chance than the IMD piece. There's a lot of concern, just outright objection for some committee chairs for IMD. So. Yes, please.
Again, I would say like the recent move with New York City, maybe we'll be raising people's, advocates' concerns about inappropriate institutional care and making even less for that exclusion.
The committee chair I'm thinking of is in the majority in the House currently, and he would be in the minority in the House. And there seemed to be a little bit of an appetite from Republicans to please discuss the IMD. Go you and then Ron.
Okay, so do you have bill numbers associated? So if we wanted to be advocates and contact our Congress people, do you happen to have bill numbers for all these? Okay.
I can track those down.
Okay.
If I don't have them, I can track them down easily.
Okay, because I mean, you seem to be familiar with these, and I am not. I haven't looked at things at federal law.
You're probably more sane for it. You're probably happy when you're
Well,
but yeah, we can definitely connect.
that'd be great.
Yeah, going back to what you said regarding why is it important for local funding, answering Jason's question from Winnebago. And I've been out there working with a number of the groups that formed new mental health commissions just in the last election. And your position is exactly what I started with, and then I continued in what's happened in Illinois. The last time there was this growth in mental health and social service funding was in the late 70s. And we have experienced 40 years of cuts, and just think of the changes when an administration changes. Think of what happens when you get a governor that doesn't have a budget, or doesn't want a budget, or a governor who goes to prison, or a governor, or just all of these other things that happen. And I can't tell you the number of agencies that, when there wasn't a state budget in Illinois, that were so thankful for community mental health boards checks every month.
Right.
And it really kept a number of agencies open. So locally, that's been the message that I've given out. And I know you've got 50 states to deal with, but I wanted to add that on top of it. When you're dealing with someone who says, well, why do I have this property tax? Well, we have had so many programs that just disappeared over the last 40 years. And in fact, I was extremely depressed when I was at the governor's announcement of all these youth service and social service fundings, because I've run agencies, I've run United Way, I've run everything, and it's just was year after year of cuts.
I appreciate that. And it's difficult to tell the federal policymakers that, like, depending on the wind's blowing our way currently, but it could easily go the other. I mean, I remember this is 5 years ago, I remember this is 3 years ago, where I'm not gonna say the agency, but a lead of a federal agency came out against fentanyl test strips, came out against harm reduction, And now in 2 short years, we have funding for it. So it really depends, and can't always assume that the federal government kind of backstops. Even with the Medicaid funding, I saw the scars from the Affordable Care Act repeal debates in 2017, where they talked about block granting Medicaid. So if we look at Medicaid funding as kind of backstop, we also have to protect the systems involved, and that sometimes is political. Any other questions? I only had 3 copies, right?
I think they're all for me.
I tried. Thank you.
It's not.
Reviews. They might be like. Yeah. I think we could take
I've got yours slide on, you said that, right? I said it.
It'll just take a few minutes, get set up. If anybody needs to grab anything, you have 3 minutes. Yeah. Yeah. There you are. Okay.
Oh. Okay, so then my notes are
Get started with introduction.
Then
First, I wanted to say thank you to Jonah for his presentation today. And we're going to move in again to the Children's Behavioral Health panel at this time. And I want to start with reference something that Jonah said, and that was the Surgeon General's report. And we know that we look at pre-COVID because we think what's happening right now is not something new. It's not new. Children were struggling before COVID. And if you look at the Surgeon General's report, you will see that. There was over 25% of youth that were struggling with anxiety, depression, and suicidal and thoughts and ideations, and even attempts of suicide. So this is not a new problem for us. But now post-COVID, we're seeing increased numbers. I know talking to our local schools, talking to mental health professionals, prices off the chart. I know ours is double in terms of prices called. And in the Surgeon General's report and some of the other reports, 80% of children receive mental health treatment, which sounds really good, but think the alternative 20% are not receiving treatment. So really good to have our panelists here today. They're all working in children's behavioral health in different aspects. So thank you first for being here and bringing your expertise in what you do. Heather Higgins Alderman will be our first presenter. I know her from her system of care work. I worked in St. Clair County and we had submitted a proposal for some system of care work. I know Livingston Township, they have a system of care grant or had a system of care grant, and they've shared that with our Children's Behavioral Health Committee over the years and the work that's done there. And I know you from the Illinois Children's Mental Health Partnership and your representation there. So Heather Higgins Alderman is the president and CEO of Illinois Children's Healthcare Foundation, the only statewide private foundation in Illinois focused on the health needs of children, which includes behavioral health. To date, the foundation has awarded grants of more than $131 million to over 500 programs aimed at improving children's health. Prior to joining the foundation, Ms. Alderman served as the Vice President for Advancement, External Affairs, and General Counselor to Pillars. Ms. Alderman's work at Pillars followed a legal career, which including a partnership at Cole, Grasso, Fensel, and Skinner, as well as more than 20 years of litigation experience. In 2015, Ms. Alderman completed 16 years of school board service, having served on the Western Springs District 101 Elementary Board and the Lyons Township High School District 204 Board. Ms. Alderman earned a bachelor's in arts in economics from the University of Notre Dame and a JD from the University of Illinois. I'm just going to go ahead and introduce each of you, and then we'll bring you up, Heather. And our second presenter then will be Dr. Nicole Summers, Gabar, and just found out she drove in from Oak Island, so St. Clair County folks, she's from there. And we found out that also she's doing a project in Alton, which is Madison County, so we appreciate her work there as well. And she's going to be speaking to us on community needs assessment, and we all know what that means and are all involved in that in our work. So Dr. Nicole Summers Gabar is the Director of Social Innovation and Assistant Professor in the Department of Population Science and Policy at Southern Illinois School of Medicine. She has received her PhD in experimental psychology from St. Louis University. She is on the board of directors for the Knowledge Center of Chatham, and she recently served on a technical expert panel for SAMHSA. What does that acronym mean? I'm not giving you coffee, sorry. Her current work is divided between two tracks, mental health and hospital community health needs assessments. Her passion has driven her into transforming rural communities to use evidence-based solutions to propel youth's lives in a positive direction. To support this work, the past 4 years, she's obtained over 1.2 million in grants and contracts from places like Blue Cross Blue Shield of Illinois, the Illinois State Board of Education, the Illinois Children's Healthcare Foundation, and local rural hospitals. This year, her work with Hillsborough Area Hospital was given an Outstanding Rural Health Program Award by the National Rural Health Association. And last but not least, we have Christine Herman. And she will be presenting to us on Pathways to Success, giving us some updates and clarifications to what's happening with that. Christine Herman is the Bureau Chief of Behavioral Health of Healthcare and Family Services. And in this role, she's responsible for the oversight and administration of behavioral health services for Medicaid eligible individuals in Illinois. Ms. Herman also administers several behavioral health programs for children, including the state-funded Family Support Program for youth who need community-based or residential services, the Specialization Family Support for youth who are in psychiatric hospitals and need extra services to support discharge to community settings, and is responsible for the implementation and administration of the Pathways to Success program for Medicaid eligible youth with complex behavioral health needs. Christine has a master's degree in clinical psychology and over 25 years of experience in monitoring and administering children's behavioral health services and programs in Illinois. So at this time, Heather, if you would come and present for us, thank you.
So good afternoon. It's a real pleasure to be here with you this afternoon. I'm going to acknowledge that this is the first time that I am speaking in person since the pandemic. And first things first, I would like to wish you all a happy birthday. So congratulations to ACMI for 50 years of service, supporting the mental health of every resident of the state of Illinois. It is remarkable work which you do, and that's part of where I want to start this afternoon is from a position of gratitude. Really, it's a privilege and a pleasure to be with you this afternoon, but really, I want to thank each and every one of you and your staffs and your teams for the work that you do every day. We all realize how important everybody's mental health is, and you're making a difference in people's mental health, and particularly in children's mental health. So thank you for doing that. I got this lovely email from Jody, and she asked me to come speak, and she asked me to do two things. One of them was to talk about our current efforts and initiatives, which I'm very happy to share with all of you. And then she asked me to think about the role of mental health boards in improving children's mental health. And I have to say, that is what you all are doing, and I'm sure that there's a lot that I could learn from you. So I'm happy to share the ideas and the thoughts that we're having about children's mental health these days. And I'm happy also then to talk to any of you afterwards about ideas that you have that could influence our work, because that's where we are in terms of trying to learn and understand what's going on in this field. I'm going to talk a little bit about the foundation itself, a little bit of history. So And some of it was in that introduction, so that was good. I'd forgotten that I handed that in, but our vision is that every child in Illinois grows up healthy. It's a big vision, and it's a vision that I think everybody in this room shares. And more importantly, I think that it is a vision that can be fulfilled. If we continue to work together and move forward together, there is no reason, in fact, it is a human right that every child in the state should be able to grow up healthy. And so that is the place from which we do the work at the foundation each day. As we think about ourselves as an organization, we are a learning organization. So I'm here to learn from you today and hopefully provide some new information to you. We're an organization that is currently very focused on EDI, like so many organizations since the murder of George Floyd and the racial reckoning. We've been more intentional in thinking about our work in terms of an equity, diversity, and inclusion focus. And so we actually have created a health equity and social justice work group and have worked with a consultant over the past 2 years where we did an organizational analysis. We created an EDI action plan, and one of the focus areas of that action plan is our grant making. So how do we think about our grant making through an equity, diversity, and inclusion lens? We are an organization that is not afraid of failure. This is something that we say to all of our grantees, and some of you are in the room, and I don't know if any of you actually believe us when we say that, but we do mean it, because we understand that the only way that we're going to change things and move things forward is to try things, and sometimes things fail. And the only important thing is to try not to repeat failures. We have a focus on integration, and you'll see that as a theme in the work that we've done. So one of the things that we're always trying to keep in mind is that the primary populations that we're trying to serve are communities who are in need, who are underserved, and the importance of trying to make things as easy as possible for them to get the services that they need. So we have supported projects that have integrated children's mental health services and primary care settings that have brought together it is working over there. So as I was saying, I'll keep going and see if we get interrupted. Part of the first time speaking after the pandemic, right? So I'll focus on integration. So, we've actually worked on projects where we want to make sure that everything that a family needs is in the same place. So your mental health services, your primary care services, and your oral health services. Anything that we can do to ease the strain on families that are in need of services. We also come from the stance that communities know best. So we work hard. We may fail at this sometimes, but we work very hard to listen to communities and understand what they need and then try to support those needs through our grant making. And sharing learning is imperative to us. And so I'm hopeful that there are a few things today that you are going to learn that's new. And we are always continuing to learn and understand what's going on, and really want to take the opportunity when we can to share what we learn from our granting partners. We are really privileged to work with organizations that are on the ground doing the work, that are learning things, and those things should be shared with other organizations so that everybody can benefit from that learning. I'm going to talk a little bit about our work now. And I've titled this slide ILCH Outside Our Box. So I think, people have mentioned you're familiar with our system of care work. Today, the Chicago Coalition to Save Our Mental Health Centers got a grant. And that grant, they were notified of the award, is a $10,000, what we call Spark grant. So at the foundation, we have a pool of $50,000 that is discretionary money that is used each year to spark some kind of activity at an organization. And these are usually $5,000 or $10,000 grants. And this year, one of them is going to the Chicago Coalition to Save Our Mental Health Centers. And what we're funding there are 2 child-focused community mental health needs assessments. So the coalition is a Chicago-based organization working to ensure that all residents, especially those who are low income and underinsured, have access to mental health services in their local community. The coalition pursues this goal through the creation of, and this is a new term for me, expanded mental health services programs. These programs are conceived and spearheaded by the coalition with communities and allow those communities to create new sustainably funded mental health centers through the passage of a binding referendum. To date, the coalition has created 6 of these And our funding will help them create 2 more of them, and those will be located in the Westtown Humboldt Park area, and then also in the communities of Woodlawn, South Shore, Hyde Park, and Kenwood. So I think it's an interesting way that they're approaching the work, and we're happy to be able to partner with them in this somewhat unique way to understand the children's mental health needs in these neighborhoods that they're going to move forward with. I'm now going to spend a little bit of time talking about our system of care, and many of you are familiar with it. It's work that has been going on since 2010 and represents an investment to date of about $40 million. So we started out with 4 communities in 2010, and those communities are in blue on this map, and some of them are represented here today. And what we were really trying to think about is how do we break down silos and create integrated approaches to children's mental health care across a community. And in those first 4 communities, one of the greatest learnings we had is the importance of time. So as that first set of communities was conceived, the foundation's plan was to do a year of planning, 3 years of implementation, and 2 years of monitoring. What we found was that it took a lot more time to do that work than we had contemplated, and we actually ended up funding those communities in some way for a total of 9 years. So when I started at the foundation in 2013, the second day that I was the president of the foundation, our program officer for mental health got sick and never came back to work. And so I had to learn how to become a program officer at the same time that I was learning how to become president of the foundation. And there were a couple of those communities, those 4 communities where the project were 18 months old and were at risk. And there was some inclination by some staff and some board members that maybe we should end those projects as opposed to continuing them. And I was fortunate to take a road trip and spend time in those 4 communities. And I came back to the board and used the analogy of an aircraft carrier. But you know what? These communities are like aircraft carriers. They move slowly and they move carefully, but they are in fact moving. And we not only should not stop funding them, we need to fund them more and we need to fund them longer. And so that was really one of the key learnings that we had in these projects. When those projects were completed, we moved on to CNHI 2.0. And one of the things that we did with the 1.0 communities is that we gave them grants that if they wanted to participate as mentors so that they could help the 2.0s do their work. We also gave grants for advocacy so that we could help them build a cohort that could work with the Shriver Center to do advocacy on behalf of children's mental health. So the 2.0s are in the middle of their projects right now. And one of the notable changes in the 2.0s versus the 1.0s is that we really included the importance of parents and consumers as leaders in this initiative. In 1.0, they were participants, but really they have a leadership role in the 2.0s, which I think is consistent with understanding the needs of community, that the professionals really need to be listening to the community and what they see as their needs. So those are 7-year projects and they're just about in the midst of them right now. And we got those projects off the ground and then the pandemic hit. And one of the things that we, like I'm sure you have seen in your communities, is our expectations had to change in life with the pandemic. And so we have certainly given all of our grantees the opportunity to take more time, to not file reports on time, and try to be sensitive to them and really find ways to support the children's mental health system in the face of the pandemic. So what that meant was that we, pandemic hit in March. In April, the board approved an additional $5 million in grant making. So we typically do about $5.5 million in grant making each year. And they basically doubled what we were doing. And the other thing that we realized we needed to do is that we had never given general operating grants before. And we also have fairly complex applications sometimes. And so we worked to streamline our applications and did some general operating grants. And one of those general operating grants went to support SAF services across the state of Illinois, because we understood that organizations were not being able to go out and provide those services, that there was a revenue shortfall. So that was one of the things that we did in response to COVID that was specifically aimed at the children's mental health system. The other thing that we did was that when we did the CNHI 2.0 grants, they were really complex applications, and those of you who have done a system of care application understand the work that goes into putting together all of the people that work on it and then completing that application and ultimately getting it funded. We could only fund 5 when we did 2.0, but there really were 10 other communities that put in excellent applications. And the usual practice in philanthropy, when someone has put in an application that's declined, is that it goes away and you don't ever think about it again. We couldn't stop thinking about, I in particular could not stop thinking about these other applications. So we had conceived of a possible approach to funding more communities right before the pandemic, because we were going to try and reach out to other funders and see if we could do a funding collaborative to get more of them funded. And in preparation for that, had reached out to this next cohort of 10 communities. And one of the things that was most impressive to us and that we're trying to figure out how we can further support was that all 10 of them had continued to do the work together. They had not gotten funded, but they had continued to meet. They had continued to try and figure out how do they break down silos? How do they create systems of care within their communities? And that was inspirational to us. And so while we could not fund all 10 of them, and we could not fund the next 5 at the same place that we had funded the previous cohorts, the board did approve what we now call CMHI 3.0. I don't know how many .0s we're going to have, but we're at 3.0 right now. And so those were 5 more communities, and they are in orange on that map. They got 4-year grants, and the grants were a little bit smaller to try and build their systems of care. And so that was one of our responses to the pandemic, was that we needed to find a way to lift up more communities and help them do this work. The other thing that happened was that at the end of 2020, the board of directors approved $15 million in additional response money to COVID over 2021 and 2022. And so we will have done $20 million in grant making directed to COVID responsiveness at the end of this year. Of that, a little over 8 million of it was directed towards children's mental health. What we did with that work is that we really wanted to do 2 things. We wanted to get out and listen to people. So in connection with that grant making, we had 16 listening sessions. We listened to parents and to youth and to mental health providers, to other stakeholders and fellow funders to try and figure out what would be the best way to deploy these COVID dollars that we're going to offer use. And where we landed, and one of the other pieces I should tell you is that when we started to do our equity, diversity, and inclusion work, we made a commitment at the end of 2020 that $2 million of our COVID funding would be directed to communities that were disparately impacted by both COVID-19 and by the impact of structural racism. We didn't do that particular grant making in 2020, but moved it over into 2021 and actually increased that amount of money from $2 million to $4.2 million. So our COVID-19 school wellness initiative really happened in 2 parts. The first part was directed towards the city of Chicago. And we selected 14 zip codes in the city where the populations were disparately impacted by COVID-19, either by, according to population, by deaths or illnesses, and then also we're suffering the impacts of structural racism. And so those 14 communities, zip codes were selected, and what the initiative is that we wanted to pair schools with community mental health providers. And part of what we heard from our listening tour was not just students were being impacted by COVID, but so were the adults who were taking care of them. So their teachers, the school staff, and their parents. So when that RFP went out, it allowed the schools and the community mental health providers to apply for money that would be spent, not just on student services, but also related to parents and to staff. And so there were 14 grants made in the city of Chicago, and then we looked statewide. We chose 14 counties across the state that were also disparately impacted by COVID-19 and also had a certain set of needs. And we used the Erickson Risk and Reach report to understand the kinds of needs that those communities had. and chose 14 of them. So each one of those grants is a 2-year, $300,000 grant. And we see them potentially as sort of the seeding of the beginning of a system of care, that maybe out of that will grow some community work, and some additional, provision of services for children and for their caregivers and for their school staff. So that the Chicago piece represents a $4.2 million investment in those 14 zip codes. One of the things I mentioned that we needed to be responsive to COVID in our grant making is that particularly in the school wellness initiative, we're seeing that those communities have had a hard time spending that money and doing the work because of the impacts of COVID. And so we will likely be extending the timeline for that work. We also have evaluations associated with each one of these cohorts of grants. And we're seeing also that we'll probably need to be extending our evaluation timelines around that work. What we've learned, what our grantee partners have taught us about our system of care work, I think is part of what I've already said today, is that it's important for our work to be community-based and family and consumer-driven. These system of care projects embed children's mental health into all structures, and we really believe in the importance of doing that. What we have seen is a decrease in stigma in communities that have built systems of care. We've certainly seen an increased access to care. And by and large, particularly the 1.0 projects, which have now stood on their own, the work has been largely sustainable, which is very gratifying to us. In terms of lessons that we've learned doing this work, again, the communities know best. We have learned that schools are an excellent location for these services. When we first did the 1.0s, we really thought that primary care offices were going to be the place that this was really going to work. And we learned that really schools were the best location. We learned again that it takes time, that communities need time to do work. Nothing happens in a year, a little more happens in 2, and you can really start to see things changing in years 3, 4, and 5. We learned about the benefit of champions or coaches in these projects. And so having an expert, a champion in a community who's a primary care provider, one who is a teacher, one who's a community mental health provider, really helps to move the work forward and encourage more to be part of it. We've understood how important community members are, and so is funding. And coordination is important, and so is funding. And that's one of the things that we keep in mind, is that the funding is really necessary and needs to keep coming. Then I'm going to talk a little bit about our most current work, the grant making that we've done this year. So like all of you, we have been concerned about the workforce for the children's mental health services. And I think it was mentioned that the need for services was drastic before the pandemic and only worse now. And I think you can say that about the workforce as well. The needs were there before the pandemic and they're worse now. So what can we do to try to improve them? One of the things that we did this year is that we did a grant to the Jane Addams School of Social Work. It's a grant that we co-funded with the Koch brothers Foundation. And what we're funding is 10 diverse Masters of Social Work students. So we're trying to increase diversity in the workforce. And 8 of them will be getting scholarships in addition to stipends. And then there's particular attention being paid to them in terms of enhanced training, field placements, and outreach, and really an effort to make sure that the students who participate in this are interested in children's mental health and interested in serving and providing children's mental health services in communities of need. A second grant that we did this year is with CBA, the Community Behavioral Health Association of Illinois. Some of you may be aware of this grant. Again, we co-funded this with Koch brothers, and we are always looking for more people who would like to co-fund children's mental health services with us. So if you know anybody, please let us know. And this, I think, is a really interesting grant. You know, one of the things that we know is that both in the pandemic, and I think really when we changed to a fee-for-service approach to mental health services, the ability to really provide supervision and pay attention to interns and give them the attention that they need got stretched. And so what happens in this grant is that SIPA actually put out a grant application to community mental health providers, 6 of whom were chosen. And they will get a stipend of $40,000 to help pay for half-time for a person to actually do the supervision. And they'll be supervising 4 master's levels interns and then, and 2 early career staff. So this will happen over 2 years. So at the end of the 2 years, there'll be 48 individuals who have been, have had these internships and have learned through this process. And there's a hope that this will be successful enough that maybe this approach will be taken up by the state and will happen statewide. So, so we'll be interested to see what happens with that. So that's one of our newer approaches to thinking about workforce.
Which university or college or whatever that are you partnering with for those internships? Things on that.
So in this, the partnership is with the community behavioral health providers. And to be honest with you, Ron, I don't have the list of the names of who was
I was
chosen.
just curious.
I meant to do that before I walked out the door today, but so it's the community mental health providers, so they're doing the supervision for the people on their staff.
Because I'll bring that right into the Illinois Mental Health Planning and Advisory Council with Director Albert and push for that because workforce is on our agenda.
I will provide that to you tomorrow.
Thank you.
Whereas peer support incorporated in the workforce development.
We've not really been focused on peer support, but that's something that we certainly could be thinking about.
Okay.
The last thing that I want to share with you is actually a model that we worked on in the oral health field. And so one of the things we were recently talking to some people about workforce development, and one of my colleagues that I was talking to said, you know, in Illinois, we have no shortage of adults. And how can we think about training those adults so that they can provide sort of the basic levels, you know, sort of the community health workers sort of model, the family resource development model. How could we really activate a large number of adults, be able to be supportive in terms of children's mental health? And I don't have the answer to this, but you know, so that we could start to really have people work at the highest end of their credentials. And one of the things I will tell you, a project that I did not put up here was a project that we did in the city a number of years ago called C3. And in that project, we worked with 2 federally qualified health centers and embedded mental health services in their sites. But we had family resource developers who were part of that project. And part of what we learned in that project is that a lot of times parents and families need very brief interventions. And I'm sure that you all know this, you know, they need a connection to housing or employment or to basic needs. And if you can meet those needs with someone who's a peer who understands where they are, then that improves their mental health. And so the model that that I'm going to talk about in terms of oral health, we didn't actually fund this particular grant. We did an initiative with Delta Dental of Illinois where they funded half of the grants and we funded the other half. So this grant to Miles Square was not in our funding pool, but what they're working on is a dental assistant program. And part of what is coming out of that is that it's a 12-week program that it takes high school students and starts them on a career path. And so one of the things that we've been thinking about, and they've actually had a couple of students who've gone on to be dental hygienists, and a couple have even gone on and gone to dental school. And so to think about ways that we might be able to do something similar, we've been talking about how do we reach out to high school students and encourage them to enter this field so that we really can fill the field with the number of workers that are needed. So I'm just using that as an example of a way to maybe think about the children's mental health workforce. And with that, I just want to say thank you to all of you for the work that you're doing every day. It really is a pleasure to be with all of you today, and it's a privilege to get to do the work that I get to do each day at Illinois Children's Healthcare Foundation. And I want to encourage you in everything that you're doing so that we all can get to a place where every child in Illinois can grow up healthy. Thank you. But I have to leave on that. That's easier, because I can make it that way. It's not kind of disrupting. I mean, you can. And I want to say thank you, I'm honored to be here today. I know, the Illinois Children's Healthcare Foundation, that really revved everybody up. I think it was a great positive start to this panel. So I'd like to start today by sharing a quote with you. And there's a quote by Carmina Substano, and he once said, "Believe what you wish, but prove what you can." And I like to think of this as the way that I actually approach community research. And there's always going to be, news stories and gut feelings that attempt to describe why communities are suffering with high depression and suicide rates. But the best way to act on it is to really find the evidence to support your path and the right people to make that happen. Now, just to go over what I plan to cover today, I'm going to share just a little bit of some of my current work in the department, and then I'm going to describe some challenges often faced in program implementation. Then what I really hope to do is share some interesting strategies and tools that you guys can actually use on your own to hopefully improve any kind of program implementation work that you're doing. And finally, I kind of want to put this into context and describe how some of these strategies can set you up better for funding in kind of a post-COVID-19 world. Now, I joined SIU School of Medicine in 2018. And since I've been there, I've worked with rural schools, I've worked with rural hospitals, and I've also worked with some local nonprofit organizations to really transform the mental health of children and their families. Now, my mission has been to decrease silos and make community voice shine. And to achieve this change, that has been through evidence-based programming and by asking residents what they really want to have. Now, there are 3 communities that I'm currently working with, and those are Hillsborough, Nokomis, and Mount Olive. I am also collaborating with somebody on Alton, but I'm not heading that project, so I won't talk about that one today. Now, in each of these communities, I start with conducting a youth needs assessment to explore the risk factors that contribute to poor mental health outcomes and to understand the protective factors that can mitigate the daily challenges that youth experience. Now, of course, communities have access to data that's already out there. There's the Illinois Youth Survey, there's the Kids Count data. But when it comes to rural communities, there's a lot of challenges faced with actually using this data. One, it's not necessarily representative of a school district. So there are some Kids Count data, and I absolutely love Kids Count. I mean, it's such a great resource. But in one of the communities that I was working with, they only took data from 1 grade and 1 school in the entire county. And it's really hard to figure out the best way to invest your money to help youth based on that limited amount of data. And another thing that's really an issue is you don't understand how everything connects. You can see where the key issues are, you can understand the state of mental health, but it doesn't tell you why it's a problem. Now, Hillsborough, they originally came to my department and they wanted us to recommend an anti-bullying program. And the reason for that was because they thought that bullying was the reason that suicide rates were increasing in the community. But there was nothing really objective to support that. There was a lot of anecdotal evidence and stories that were shared. And so what I did is I was able to convince Hillsborough into the value of collecting their own data before actually going in and investing into programming. Now, we started with a youth assessment in fall 2019, so right before COVID.
And this was a 2-day assessment completed during the school day online, so we were given some class time. And what I found was that 1 in 5 youth thought about committing suicide within the past 12 months. And 1 in 3 students had abnormal levels of depression. And I had multiple depression measures to make sure that these same patterns kept coming out. Now, using some statistical analysis, we found that the biggest risk factors to explain why students struggled was due to commitment and low commitment and connection to the school, family conflict, and bullying. So yes, why bullying was one of the risk factors associated with suicide and depression. What we found was, first, it wasn't the only one, and second, it wasn't the most significant. There are other ones that had a greater impact. So we took this data and we shared it back with a coalition of community members, and they shared some concerns and stories and explanations for why mental health was such a big issue and how they thought they could bring about change. And my team and I, we took this information to search for evidence-based programs to address their risk factors and leverage their protective factors. And then we brought this list of programs back to the community, and they actually voted on what they wanted to see, and Hillsborough Area Hospital invested in it. And today we continue to collect data to examine the community reception of these programs and the effectiveness of these programs. Now, the same kind of process was carried out in Nokomis and in Mount Olive. And I believe it's really vital to examine each community individually, even if they're in the same county, even if they neighbor each other. Mental health is a prominent issue everywhere. We know this. We wouldn't be here today if everything was hunky-dory. But not all communities face the same challenges, just like not all communities have the same exact strengths. So for instance, we can take Nokomis. Nokomis was the next community that I worked with after Hillsborough, started to kind of like catch on, and communities were really excited about doing some kind of mental health work. And Nokomis actually originally wanted to just go right in and implement one of the programs that Hillsborough is doing called Sources of Strength. It was a program that focuses on positive youth development. It's really, really easy for people to sell to the community and get behind because it has such a positive point of view that it comes from. The kids were really excited because they're the ones that actually implement the program. So Nokomis was like, let's do it. And I said, hold on a second, let's wait. I would love to implement this program. It's going to be so easy because everything is in place. But we need to see if you guys are having the same issues, even though you're in the same county, you don't know. So we did an assessment there too. And what we found out was, no, they're neighbors, they're in the same county, but they do not have necessarily the exact same issue. So in Hillsborough, the risk factors that we found, they were identical for the junior high and high school. Remember, those were like low commitment to school, family conflict, and bullying. When it came to Nokomis, we found that there were differences by age. There were some similarities, family conflict and bullying, but for the junior high specifically, we also saw that early initiation of drug use and early initiation of antisocial behavior, which means that they're starting things at a young age, that their friends are encouraging them, were really the biggest issues related to suicide and depression. And for the high school, community disorganization was one of the risk factors, which was completely different from what we saw in Hillsborough. And when we shared this data back with Nokomis, they completely changed their tune. They said, no, this program that we have that we're looking at is a great program to use, but it's not the best fit for us. And they actually went in a completely different direction, but a completely different set of programs because of that. Now, there are 3 key challenges that I really see with doing program implementation work. One is the lack of understanding the root cause of issues. And this is something that I've started to talk about already, but I'm going to get into a little bit more soon. The second is a lack of community buy-in. And then the last part is not having a sustainable plan in place to make sure that the work can continue. So one of the biggest mistakes I see when implementing programs is that many assume that what works for one community is necessarily going to work for another community automatically, just like we had saw originally in Nokomis. However, what works in Chicago is not necessarily going to work in rural Illinois. And what works in rural Hillsborough does not necessarily work for rural Nokomis. So one size does not necessarily fit all. Now, community buy-in, as I said, is the second biggest challenge in successful program implementation. And while money can do a lot, it is not really the end all be all for solving community-wide issues. So I'm going to give you a really interesting example that I love to share with people. In 2010, Mark Zuckerberg, who we all know from Facebook, pledged $100 million to turn around Newark schools in New Jersey. And he hoped his investment would bring a model that could be used to turn around a failing school system that other people could replicate. And doing so, Zuckerberg and the mayor of Newark actually sidestepped community collaboration by thinking that stakeholders could never reach a consensus. Instead, Zuckerberg hired a leader from outside of Newark to serve as the superintendent and created a board of philanthropists from outside of Newark. And just 4 years later, in 2014, 77 local ministers pleaded with the governor to drop this project because it was creating a toxic environment in the community. And this is a perfect example of how not to accomplish community change. Now, another key concern in implementation is around sustainability. And I think this is just such, it's a sad and interesting fact, but research suggests that actually up to 6 years after adoption of a program, about half of the programs actually continue. Moreover, when programs can drop off, community members tend to lose trust in research, and they lose trust in the organizations that instilled it in the first place. So if there's no community buy-in, the potential for any future programs could really be lost. Now, these challenges are exactly why I like to use something that's called a community-based participatory research approach. This will be my only acronym, CBPR. And it's a great way to shape communities, and I'm going to talk to you about this today. CBPR is a research process that pinpoints local problems, assets, and needs. It identifies and builds on strengths, resources, and relationships that already exist within the community to address health concerns. And it prioritizes, this is really important, power sharing, collaboration, and equitable partnerships in all research phases. So CBPR can look like a lot of different things when it comes to both the research process and implementation. And it could include things like changing the length of the assessment, the topics on it, how to handle gender identity, and how to better serve students with special needs. So I'll give you a few examples. In Hillsborough, they really wanted to spread the survey out over 2 days because they wanted to reduce fatigue in students. So we we had more measures than we normally would because we had 2 days, which is so rare in school. But we made sure that we didn't have a survey that lasted more than 30 to 45 minutes per day. Now in Nokomis and Mount Olive, that survey was condensed to 1 day, which was fine. We have key components we like to use, and if we have extra time, we'll add some extra measures. And another example, the Nokomis Coalition wanted to do special additional analysis about vaping to ensure that that wasn't a contributing factor because they found that vaping was such a prevalent issue in their school, they thought it had to be related to mental health. It was not, but we did the analysis anyway because that's what it is to be a collaborator. And a third example, I won't necessarily mention the school district because I know this can be controversial, but the school district wanted to make sure that we had more gender fluid options on the survey because they knew that this was an issue that has kind of emerged more in the school, the way that students identified, and they wanted to know, what is our student population? What is the best way to address them? Other communities are not that receptive and they're afraid that parents are going to get upset. But that's the nice thing about being flexible. We can be there for our community partners and we can change these items to make sure we're capturing exactly what they need. Now, a last example that I want to use is from Mount Olive. And this is a new thing that we've just done this year, and I'm really excited about it, is that we were able to actually integrate a kind of text-to-speech feature in our assessment so that we're better able to integrate students with reading challenges. Now, this doesn't necessarily include all students with learning disabilities, but it's really nice that we're able to take an extra step to be more inclusive. So this is an example exactly of what that looks like, and every time you kind of see a little speaker, it will read the questions and it'll reread the response options to you. So students can kind of just click along, they can even click with the instructions, they can go back and forth, whatever they like, and you can choose the voices, which is really fun. Now, when it comes to actually addressing the root cause, one tool I really like to use, and I'm excited to share with you guys today, is something called Blueprints in Healthy Youth Development. This is a website that's actually designed by the University of Colorado Boulder. It is not a clearinghouse, and it tends to be funded by grants. However, what's really unique about it is that you can go to the website and actually apply some filters, and programs are going to pop up to be recommended to you. So you can actually filter for certain risk factors that you might want to address, certain protective factors that you can. You can actually filter for demographics. This is something they want to do better, but there's already movement in it, so they have a couple of different ethnicities that you can filter for. I think you can filter for gender. And there is sometimes information about rural and urban areas and age groups. That's a really important filter to be able to have. And then you can even filter for location. So if you want a school-based program, you can filter for that, which is really exciting. And in addition to all of that information, I think one of the really savvy things about this is that it will tell you about the degree of evidence available to support the effectiveness of that program. So they actually give different kind of ratings, and the programs that have the highest ratings are going to be ones that are actually in clinical trials, multiple clinical trials that have been randomized. And then, of course, there are some more modern, newer programs that might have not gone through those rigorous trials yet. And they share that information with you so you can kind of make the best decision possible. And they share what those actual findings are, and they share a list of some articles that you can actually go back to kind of confirm those results, which I think is really exciting. A final thing that I think is really important on this website is it will give you a person of contact. So you don't even have to search that stuff down. You know exactly who to go to, because the website itself does not run the programs. They're just a resource. And so you will know exactly who to contact if you want to actually implement this program yourself. The only thing I keep caution on is pricing always changes. Prices in general, I think, are very good on all of the programs that I've seen, but take the price that you see with a grain of salt, because they can't always, update this consistently because they don't have that federal funding. So it's something they have to do every time they get a grant. Now, in the case of Hillsborough, their coalition started with 9 voting members. 9 voting members, such as myself and a few others were not featured. This is the group, this is the original group that we have in Hillsborough that made all of the decisions about these processes I've been talking about. And the non-voting members tended to help with things like administrative work, helping with transitions, but we have no power to vote. All the board members resided in Hillsborough, and the board consisted of a retired sheriff, a pastor, a school superintendent, a school counselor, a business owner, 2 youth, 2 parents, and at least one of the members was a non-native English speaker, and at least one openly identified as part of the LGBTQ community. The school counselor was invited to serve as the chair, and the hospital actually provided a project manager later on to help coordinate meeting logistics, such as meeting space, printing, and meals. And coalition meetings were hosted monthly at the local hospital, and then when COVID came, because as I said, we started this in 2019, these meetings were switched to Zoom so they could continue. Now, having a coalition like this has really helped us in so many different ways, including, but not limited to, the interpretation of the data, understanding the fit of the program, and actually being the boots on the ground to implement a program. To form these coalitions, we always first think about who do we need to make this successful. Is it a school administration person, or is it trained mental health professionals? If there are teachers running the program, are teachers at the table for conversation? Are there any partners who could provide additional funding or resources? For instance, our public health departments at the table, or our other hospitals who can contribute community benefit dollars at the table? And what kind of skill sets do we need? So one skill set that is really beneficial in coalitions is somebody who can maintain social media channels or write news releases, because they can help spread the word and kind of give a positive outlet on your program. Now, once the coalition is actually formed, it's good to establish some kind of team building activities. That's what I found before actually diving into the real work. I think oftentimes, you understand, you see these rates where 1 in 5 students are thinking about suicide and you want to act immediately. But if the group who's doing all this work is not strong, if they don't all have the same vision, if they all don't feel comfortable communicating with each other, it's not going to last. It's not going to be sustainable. So the team building activities are really a chance to make sure you can get every voice to say something at least once in the very beginning stages, and make sure everybody knows and agrees on the expectations of their involvement. And 2 team building activities I really like to use are one around establishing guidelines, and then another one about creating a mission statement. So to run these activities with the coalition, we might start with like a large focus group, develop these, or we might have some smaller focus groups. The number that we have found in research to be magical is the number of 7. It's just enough to have a conversation, but not too much that somebody gets lost. And I'd like to start with the guideline activities specifically, because this activity helps the coalition agree on how it's going to operate and what members will deem as respectful behavior. Because like I said, they have to coalesce together to be successful. So what I'm sharing with you today is just a part of that activity that I'd like to run with communities. And I know that there's a lot of fonts on this page, so I can read some of the questions that we might ask those focus groups. Because if anybody is as blind as I am, I would not be able to see past the second row. And the 3 topics we really like to focus on are communication, respect and trust, and meeting format. So around communication, one of the things we might have them agree on is there an additional method of contact aside from email that committee members should be notified about meeting dates, changes, or cancellations? We found that this is a really important thing to jot down when we have students involved, because the students do not necessarily check their emails as frequently as professionals might do. They prefer to use something like text. So this makes sure that no communication is lost if there's meeting changes. With respect and trust, one of the things we ask them to do is decide how they would like to approach the use of technology, such as cell phones or laptops. Some people are really comfortable having laptops out and people typing. Other people think that this is really rude and distracting. So as long as the whole group agrees on it, then everybody can coalesce. And then when it comes to meeting format, there's some really important decisions that need to be made. So how do you handle, there's voting when there's a tie, if there's a tie? Or if you're having a meeting, is it okay that people can just come and go if they need a break? Or do you have to have a standard break to make sure everybody's focused? Now, when it comes to the mission statement activity, I like to focus on 3 areas here as well. But these areas are, who are you as a collective? What do you do as a collective? And where is the collective going? And it's really nice to be able to establish this mission statement activity, because like I said, it helps the group know which direction they're going, and it helps them identify how they brand themselves to the community. How do you explain the work that you're doing? And some of the questions we might ask them to talk about is, who is part of this coalition? So is it parents, is it students, is it teachers, is it superintendents, is it business owners? What do you do as a collective in terms of what is your dream or vision for where this is going to go? And how do you plan on getting there? So to give you an example of what this looks like, I do this with each community that I work with. In Hillsborough, their mission statement that they came up with, and they call themselves the David A. Engler Youth Assessment Steering Committee. They said that they will improve community engagement and positive behaviors, resulting in improved youth mental health. They will make an evidence-based decisions guided by community-driven data for youth. And they plan to maintain a diverse membership to leverage each person's unique background and sphere of influence to address the true scope of our community's mental health status. Now, being involved with program implementation for the past 10 years, I see that there are a lot of developments, new developments, which would be key for success moving forward in a post-COVID-19 world. One of the biggest considerations should be around flexibility of the program you select. Being able to have a program that offers remote training options can not only cut costs for the program and speed up your timeline in accessing them, but it has really been essential in making sure that our programs were more successful, especially when shutdowns kind of wavered on and off. We were able to at least keep on track with our training. Another important thing, or thought around program selection, as whether that program has any kind of virtual components for students or families or other individuals receiving program services. This is actually a feature that more and more programs are trying to develop. And I originally thought personally that once COVID-19 restrictions lessened, that people would prefer getting program services in person. And what I found in my work is that's not the case at all. I have actually seen in terms of students, having virtual ways to connect meant that even if they had to miss school that day, they still received program services, they still felt connected to their community. And when it came to parents or caregivers, having a remote option has been an interesting way to help families overcome barriers that they might have normally faced in the past. So how do they handle childcare services if they're getting programs? Or how do they balance students' extracurricular activities? Sports season is a really hard time to do after school program implementation. Or if you're working with rural communities and they live a long distance away from those program services, having some kind of virtual component makes it really, really easy for them to access those services without worrying about the cost or time burden of long transportation. Another key consideration is whether that program has any kind of licensing component, which is something that you should be able to find on that website I shared with you earlier. So this will help make sure that the long-term costs are reduced after that initial investment. And this year, due to part of the grant from the Illinois Children's Healthcare Foundation, Hillsborough was actually able to get one of their programs licensed, and they sent one of their school counselors and teachers to Kentucky for like this big training. They were so excited to be able to do this training in person and came back really energized. And now that they're licensed, they can continue the program. And if other schools are interested, they can come to them and get trained by them to do the program. Now, outside of finding the right program, there are other strategies that can ensure program sustainability, such as by integrating some kind of screening system. So for instance, Hillsborough, when I started with them, had just started integrating something called the Behavioral and Emotional Screening System. I lied, different acronym, BESS. I've heard of school psychologists refer to it this way. And when Mount Olive found about this screener, they also decided, hey, we need to do this too, which is really interesting because it will help flag students to be able to track or flag students to know which ones are highest at risk and need to get program services, and it can help them with longitudinal outcomes. When you are an outsider from the school and you have to deal with issues like the IRB, it can be really challenging to take identifiable information, sometimes it's considered HIPAA data, and be able to track these long-term changes on an individual level. But with this, measure integrated into the school, it makes it really, really easy to be able to find students who are in need and be able to say whether there are things being made. Now, a final thing to help with program implementation going forward is the development of task forces. Now, if you already have some kind of coalition developed, Members from that coalition can actually serve as liaisons to different branches that might work with people skilled in particular disciplines, which can promote and grow the program. Task forces do not necessarily have to be as frequent as the coalition, nor do they need to be a permanent branch. This is a great way to actually expand the reach of your program to the community, expand the participation in a manageable way that doesn't involve finding a time zone where dozens can come together, or not time zone, but finding a time where dozens can come together to meet with a larger coalition. So once again, like with Hillsborough, their coalition is about 9 members that are with voting power, and Nokomis, I think it's about 11. But before coming to SIU, I worked with other communities that wanted to have coalitions of 32, which is really great for being able to distribute the workload, but really bad for being able to find a time for everybody to come together and meet consistently. Now, thinking forward to the future, by keeping in mind root causes, community buy-in, and sustainability, not only will the quality and longevity of the work change, but it can also set you up better for getting funding. For instance, having data on the root causes will serve you stronger than using existing data that's already out there, like we talked about with the Illinois Youth Survey or Kids Count data, because you're able to understand how these factors are related. And it's going to be more representative of the true population. Now, this kind of data can actually give you a strong justification for why mental health is a struggling issue in your community, and I think be a great argument for why you're going in the direction you're going in. Next, that community buy-in from coalition members can really help serve as your key partners for applying for funding. They would be the people in place to sustain the work. They're going to be the people in place to help expand the work. And they're going to be the ones that are going to be sharing the advice with others on how to do the same approaches to the program if they're interested. Finally, by having some more systematic data collection in place, by integrating something such as the BEST measure, this is able to help better select students in need and track when change is happening. By being able to create a referral system and document success, it's really an important component to be able to integrate in grant funding. So thinking back to that first quote, believe what you wish, but prove what you can. I recommend you always try and dive deep to find out why something is happening, and by aligning yourself with the right people, anything is possible to help improve the life of you.
Oh, so do I not have any notes? Well, that's not showing where it's like on the others. I'll give them for sure. I've given this presentation 1,000 times. I can't do it by now. I should be fired. Sure. Yeah. I don't think everyone. How are we doing? We do stand up. Have a little break. Let's stand up. Have a little break. Get it all out. We have had lots of amazing information. So sometimes we gotta stand up.
How long do we have?
Okay.
You all were really good, great, Jerry, big higher things. We call them higher grades. And they did great. Okay, we'll take 5. Yeah, that's good.
Yeah, I'm like, nobody's gonna be able to have, yeah. I mean, yeah, actually, I'm gonna.
Yeah.
I looked at it, and I was like, this is gonna be an zap. Because everybody's just gonna be like, yeah, I got it. Let's see later. Thank you very, very much for the invitation to speak today. I am ridiculously excited about this new program that we're rolling out. And I'm really hoping that by the end of this presentation, you all have some really great ideas about how we can partner together to make this successful within our communities. We just heard so much about community buy-in and how important it is to know the community that you're in, know what the challenges are, and most importantly, really know what interventions need to happen. We don't need just a top-down approach. We need a bottom-up, outside-in approach, particularly when we're talking about the really wicked challenges that we have around children's behavioral health. So, a lot of what I'm going to talk about today is going to look like program nuts and bolts. And I think it's really important for first of all, to kind of understand how this program is going to run. But I also want you to see that HFS is starting to lay the infrastructure for a statewide organized children's behavioral health system. And we're really hoping that we're going to have other funders that come with us along this path to fund kids that are not Medicaid eligible, to bring in maybe some additional supportive services that maybe we're not going to be able to fund, but other people will. So I really look at this as just the beginning, and Eric said it very well. It takes time, right? This is a marathon. It is not a sprint. And this particular program has been almost 10 years in the making, right? So there's been a lot of conversation. It's taken a lot of patience to get to where we are today. So we're going to talk nuts and bolts. I want you to think broader picture, infrastructure, and partnership as we're going through. Now, I also can't see the speaker notes, so I'm going to wing it. So I'm not exactly sure how this presentation is going to go. We could be talking about football by the end. I don't know. Let's give it a shot. Okay, so very quickly, pathways to success. Now, this particular program is really geared towards complex kids.
So we're talking about kids that have a lot of mobile crisis response. They're in the ER, they're in the hospital, they're being relinquished to DCFS because they have really high-end, complex behavioral health challenges. And we're gonna bring new home and community-based services that are tailored for those kids. It's built on a very intensive model of care coordination. And it's evidence-based, evidence-informed. We're gonna talk a lot more about that, but it's really specifically for these kids. We are embedding system of care principles into the implementation of this program. And that's really important. So we're talking about youth guided, we're talking about family driven, we're talking about data driven, we're talking about culturally humble. And just making sure that really all of those principles that go towards what does the community need, what does the family need, what does the child need, are embedded throughout the system. So I'll try to highlight that as we go on. Now, it's no secret that this is, the impetus for it was a consent decree. So it's the NB consent decree. HFS was sued under EPSBT, which is our broad mandate for Medicaid services for children under the age of 21. That lawsuit basically said that we were not doing enough to provide intensive home and community-based services to Medicaid eligible children that really required those services. I'll just give you an idea. That lawsuit originally came out in 2011, and we're implementing the remedy now. It has been a long time coming. So I'm very excited that we have met this milestone. Now we are going to begin officially in January, but we do have one agency that is ready to go this month. So I'm super excited about that. I'll tell you who it is later. Leave you in suspense. You have to pay attention to the rest of the presentation. Okay, so these are the services that we're talking about. Care coordination and support, there's 2 levels of that. Family peer support, she's not with us anymore, she mentioned peer support. I was like, yes, we're doing peer support for families. We're not to kid peer support yet. That's a hurdle we can't jump just yet, but we'll get there. Intensive home-based therapeutic mentoring, and then 2 supportive services that cover things that Medicaid won't otherwise cover. Okay, so that's sort of the broad picture, right? So we'll talk about eligibility real quick. Got to be covered by Medicaid, got to be under the age of 21, have an SED or an SMI, and then demonstrate the need for intensive services pursuant to the state's IMCAN's decision support model. Now, I will be doing the rest of this presentation in acronyms. I'm just kidding, although I actually really could, because I work for the state and we can't talk unless we use acronyms. So the IMCAN is the Illinois Medicaid Comprehensive Assessment of Needs and Strengths. Okay, it's a lifespan tool, so it can be used for adults and for kids. For our purposes, we focus more on the kid items of this tool. Let me give you a little bit more information on that so that it doesn't sound like, so ominous. The decision support model that we have is based on the IMCANs. And it is really this standardized approach to identify kids that need care coordination services based upon documented clinical needs. Okay, so the IMCANs is various items that cover different domains for kids, like behavioral and emotional functioning, risk behaviors, caregiver needs and strength, those kind of areas. And you score each of those items on a scale of 0 to 3 based on the need for intervention. So it's not necessarily the severity of the issue. It is more like this item needs intervention right now. This item, we can wait on that. So it helps to prioritize and really highlight where are the areas that we really need to intervene quickly for this particular youth. Okay, so that is kind of how that is scored. We do a clinical interview, we gather the information from that clinical interview, we put it into the tool. That tool then comes to us and we apply this decision support criteria. So what it does is it takes the combination of the complexity of those items and tiers kids into 4 different levels, okay? We worked with the developer of the cans, so we wanted to go sort of right to the guy who developed it, and he helped us work through this combination of complexity and intensity of items that would best identify kids who need different levels of services and care coordination. So we kind of got it lined out, and then we brought together a group of folks from various state agencies, and then from our community-based agencies who are doing, work with the actual kids. And we had them run some tests on our decision support model to say, hey, is this, are we identifying the right kids? Does this make sense in Illinois system? We really kicked the tires on it just to make sure that, we weren't going down some bureaucratic rabbit hole that wasn't going to get us where we needed to go. They gave it the thumbs up, made a few adjustments to it. And that's the decision support model that we have today. Now, it is going to be made public. So I think this is really important. We want to be super transparent about this. But as you can tell by all the words that I just said very rapidly, it's a little bit complex. So we want to make sure when we roll it out publicly that we've given enough context so that when you go to the website and you pull it down, you're like, okay, I can see how this all fits together. So we will probably have that out in the next, probably 2 weeks. And that'll be posted on our website. And at the end, I will give you that website location. Okay, so we've talked about the decision support process. We've talked about who is eligible. So I just wanted to really quickly run you through the process that we use to identify kids who are going to go into this program. So as I mentioned earlier, we have that clinical interview. The provider then completes the IM cans. That goes into the portal. We pull that information from the portal. It automatically puts that decision support criteria against the data from that IM cans. And then it tells us, if a kid falls into tier 1, that's the most intensive tier, high quality wraparound, or tier 2, that's intensive care coordination. Those kids go into pathways. Now, if they don't go into pathways, they can still receive all of the Medicaid service array that we have in the community. So they've gotten an IM cans, they're connected to a clinician, and they can continue with services with that clinician, even if they're not eligible for pathways, because that would mean that their needs that they have really can be met by outpatient community mental health services. So I just wanted to make sure that that was clear, because sometimes people are like, well, we're not eligible for pathways and then we'll get any service. But that's not true. We don't want to do that to kids. That would not be good. So once they're eligible, they get 6 months, and then we send a notice of eligibility to the family, the CCSO, and their MCO if they are covered, but we know most of our kids are. And then they get reassessed prior to that 6-month time frame just to make sure that they're going to maintain eligibility for the program. So when I talked earlier about infrastructure, this starts to line out a front door for kids coming into services in a systematic way, right? So if you have a youth that is showing signs of behavioral health needs, behavioral health issues, and you can get them to a community behavioral health provider that does the IM cans, that is the first step in the process to get them moving in the direction of getting the services that they need. So what we're trying to do is have kind of a no wrong door approach, right? If you are a school, a church, a community center, a mental health board, and you know that there's kids that have behavioral health issues, we want to make sure you know where to refer that child so they can get an IM cans and they can start moving into this particular system. Now, again, heavily funded by Medicaid now, hoping we bring other funders along, right, to blend and braid that funding so that kids that are not Medicaid eligible can also come in through this pipeline, start building that broader system of care for children's behavioral health with multiple funding streams. Okay. Here we go. Let's talk a little bit more about care coordination and support. So what you can see here is that it is a structured approach to care coordination. But it is going to be individualized for what the family needs. I want to be very careful because when I look at this, I'm like, man, it looks like it's just a cookie cutter, one size fits all kind of approach. Wraparound assisted care is not meant to be that. It is a standardized process, right? It's a standardized process, but it doesn't mean that it is the same for every family because it's very much based on their needs. Okay, so you can see here the key activities that fall under care coordination and support. Engagement and outreach, child and family team facilitation is really a key component to make sure that all the people that are important to that child and that family are at the table. You're going to start probably with more professionals, but as they move through the process, you want that child and family team to be mostly natural supports. And by the end, all natural supports and a facilitator. And a facilitator teaching them how to do their own child and family team meetings so that they can go be successful without professional intervention. IMCANs are doing updates, mobile crisis response. I'll talk about this a little bit more, but the agencies that do this work are also our mandated mobile crisis response providers, our SAT providers. Yeah. So you said SATs and I was like, oh, really? Okay. And then coordination and consultation and referral language. So again, key activities that are going to be provided. Okay, so I talked a little bit about the intensity levels, give you a little bit more information about that. So our high fidelity wraparound, this is for our most complex kids, our kids that are really struggling right now, that I deal with on a daily basis and don't yet have really good tools for. Kids that are being relinquished in the ER, hospitalized. You all know the kids that I'm talking about. So we're going to have that child and family meeting every 30 days, very intensive. We want everybody at the table communicating very frequently about what's going on with these kids. We're going to review the IMCANs and the crisis prevention plan every 30 days, and then minimum weekly, probably at the beginning, we're talking about daily contact with these families as they're getting into this process. Intensive care coordination, meant to be slightly less intensive, but still a lot of interaction with the family. Care coordinators can handle about 25 of these families. They're doing child and family meetings every 60 days. And then you can see we're doing the IMPN's crisis prevention plan every 60 days, but again, requiring weekly contact with the families. Okay, so because this is very specialized and this is very intensive work, and it is not business as usual, right? And Heather and I were talking about culture change that needs to happen for this process to really be successful. We have designated specific care coordination and support organizations. Now, they are our local hubs of accountability and collaboration within the community, within designated service areas. We used to talk about local area networks, the old LAN system that we used to have. Well, you know, we got tired of that acronym, so we went with a different one. So now we have designated service areas. They function very much like the LANs used to function, and the CCSOs are really the organizing body within that DSA. So again, they're responsible for doing the care coordination for pathways. They're also going to take over responsibility for the family support program, the specialized family support program geared towards kids that are hospitalized, and then SAS and mobile crisis response. So they are the designated mobile crisis response provider, and they will be providing mobile crisis response for kids and adults throughout the designated service area. Some of our CCSOs have partnered with other mobile crisis response agencies. So within your area, you may have the CCSO that's sort of the primary. They're primarily responsible for response throughout the DSA, but they may have partnered with a couple other agencies just to make sure they can cover the whole area. And we can talk a little bit about that later in the presentation. Okay, so I thought you might be interested to see how the DSAs play out. I tried to stretch the map a little bit so that those of us that have progressives could maybe read it. So it looks a little funky. I'll give you a minute to digest that, so you can kind of see where you land on this oddly shaped map. If you want to see a properly proportioned one, I put the website down there, but it is partially blocked by Jody Dart, and that's just rude. I'll make sure that you won't get that information. Yeah, we can send it out, not a problem at all. Okay, so we've had enough time with that one. We'll move on to Cook County, because we can't do that by county. We did this by zip code. There was no way I could zoom in enough to get the zip codes on there, but I'll show you a list of those as we go along. But again, you can kind of get an idea of where you're at in Cook County and how that shakes out. In Cook County, we have a few CCSOs that are covering multiple adjacent DSAs, but I'll show you how that shakes out here in just a minute. All right, we ready to move on? All right, so wanted to tell you a little bit about how we went about the selection process. So we did this through a request for qualifications, which is kind of a light version of an RFP. So basically, they identified which DSA they wanted to serve, and then they sent in their RFQ response. We had a pretty diverse team review those applications. We had folks from HFS, DHS, DCFS, our NCO partners, because they're going to be contracting with these CCSOs, and some folks from the University of Illinois that helped us out with this particular process. So those that scored highest in their region were awarded. We selected the CCSOs. I'll let you know who those are in just a second. We started working with them pretty immediately to prepare for implementation. So we started meeting with them weekly. We did one-on-one meetings with every single one of them. And really we got an idea of how well they know their communities, which is going to be incredibly important. And I'll tell you, the ones you can kind of start to see the ones that are going to have early success because they really understand their communities. They really understand what's going on in those communities and how to intervene. And then there are a few that it's just going to take a little bit more time. And that's okay, because like I said, this is a marathon, it is not a sprint. And we know the culture change is going to take quite a long time. We're doing readiness reviews with them right now, on-site reviews, and asking them to walk us through, hey, you've got a kid that's going to go through this process. What's it going to look like? How do you think that this is going to move forward? And then the CCSOs that have staff hired and trained and have passed their readiness reviews are going to begin in January. I think we're going to have maybe 10 that are ready to go in January. We're getting their staffing reports right now to see who's going to have staff hired, trained, ready to go. So we'll have some start in January, another cohort in February. I'm hoping we get to full statewide coverage by March. It might be April, it just depends. I mean, we all know that workforce is a very big challenge. So some of them are just really struggling, particularly with licensed staff. So if you all can find me 100 LPHA and send them my way, super great. Okay, so real quickly, I'll let you peruse this list out. Jody's blocking Aunt Martha's wellness. I think it's funny that it's blaming her. Me. I kind of like that. Okay, so this is 1 through 11. You can see who our CCSO is, and then the areas that they cover. Tell me when you're ready to move on. We good? We're good. Okay. All right, so here's 12 through 22. Oh, and our little overachiever who's ready to go this month is on this list. It is Family Service Association of Greater Elgin. So we did that on-site review yesterday, and I was really impressed. I wouldn't tell you if I wasn't. promise I wouldn't throw them under the bus like that, but they, picked a couple of examples of kids that they have worked with. About how they're going to walk them through this process, and they had such a family-centered approach. You know, they talked about how in each of their interactions with families, they want to make sure that families find it fun and engaging and worthwhile so that they will come back. You know, that's literally the first time that I have heard a provider say, you know, it's on us to make sure that the families come back, because what I usually hear is, well, you know, families don't engage with us, so what are we supposed to do? Like, well, why don't you change your approach? I mean, you know, think about it. So they really have mastered that. I'm very impressed with that. So 21 kids this month will start through this process. I think it's a really good start because it gives us some time to see how the implementation hiccups and bumps are going to come up. The things that we thought about, but we didn't think about. And we just heard a whole lot about program implementation. So, you know, I found out I made about 100 mistakes. Great, but we'll fix that. It'll be all right. Okay, so let's move on from that. Okay, so now we're getting into Cook County, as you can see by the dizzying amount of numbers here. You don't have to digest all of these right now. This is on the website as well. And thanks, Jody, you're not blocking the social services. Great. Okay, so let's move on quickly. All right, so this rounds out all of our CCSOs. And you can see here, A to S and C4 really took over quite a bit of Cook County, which is a good thing because they have had a lot of familiarity with the areas they're going to serve. So that's a happy thing. This is also posted on the website, so you can go and peruse it at your leisure when you want to like cross match where those zip codes are because you have insomnia. Okay, additional pathway services. Family peer support. I'm so glad you came back in the room because you had asked about peer support. And there it is. And that makes me very happy. So family peer support is really, really important. And one of the things that I think is key to making any initiative like this successful, this is really geared for helping parents, helping guardians and caregivers who are dealing with their family that, I mean, these families have so much stress related to the behavioral health issues that are going on. So we partnered up with Regina Kreider of the Youth and Family. I'm seeing some heads now. That's great. She's amazing. She keeps me in check, in line, and keeps us focused on really what's the key components to making this successful. And it's making sure that parent voice, family voice is right at the center of everything that we're doing. This is really important because, you know, we're going to be bringing families into this new kind of system. And frankly, it's a system that has not served them well many times. If it had served them well, they probably wouldn't be in the position that they're in. So we're going to have that person sort of by their side saying, yeah, it's okay to not trust this, but I'm here to say that this is going to help. You know, that if you engage, you can trust these people. I mean, just those kind of things that you need to hear from somebody who's not walking in wearing a badge, you know, saying, hey, I'm a professional, I'm so smart, right? So we are looking for a whole cadre of family peer support folks. And Regina's really helping us with outreach, engagement, and development of this particular workforce. So I'm very, very excited about that. And it's a paid position, right? So I mean, now you're talking about people who can take their lived experience and turn it into a career, a meaningful career with living wages, you know, that is not just a volunteer position. So I again, very excited about that. Respite, everybody just needs a break sometimes, right? And then therapeutic mentoring. I love this service. I worked with some therapeutic mentors out of Indianapolis when we were doing a pilot project like this in Champaign, Choice Project. And they were the most dedicated guys. All they wanted to do was teach kids how to interact better so that those kids could have friends, so that they could stay in school, so that they could be a part of their community. Because what they experienced with the kids that they worked with is just a sense of isolation. Like, I can't get along with people and I don't and I don't fit, and there's nothing I can do about it. So they take these folks, these little kids, and they work with them, and then those kids can be better integrated into their schools and their families. So made me an absolute true believer in that therapeutic mentoring service. Okay, intensive home-based. Now, outside of the care coordination, this is the most intensive service in this package that we're providing. And this is team-based. So it's a clinical person and a support person working directly with the family in the home. It is very much targeted towards the behaviors that are most problematic within the home. The behaviors that the parents are saying, if this doesn't stop, this kid has to go to residential, or we need to go to the hospital. I mean, the ones where we really need to get in, we need to intervene quickly. We need to bring some closure for the family, so that they can see if they can move past that particular behavior, and there be more peace in the home. It is based on practice-wise guidelines. So practice-wise kind of goes through all of the evidence-based practices. You can go in and identify your kid, what the issues are, and it pulls up for you, hey, here's the evidence-based practices that are going to be most effective, and here's the practice guides that you can use from both the clinical perspective and then the support perspective. So we're doing a lot of training with our intensive home-based folks on the use of PracticeWise, and they will end up being PracticeWise certified. So that gives you a whole broad base of evidence-based approaches utilized things. Okay, and then the last two, therapeutic support services and individual support services. These are the ones that I mentioned that will cover services and supports that Medicaid will not otherwise cover. My favorite, equine therapy, right? So I've seen incredible things done to bring kids out of depression and anxiety with equine therapy. So very, very excited about that particular service too. And then wellness activities, special recreation, all those kind of things that can just kind of help support that family as they're working towards a better functioning. Okay, it's a lot, right? And what we want to do is, as we are building this statewide infrastructure, we want to support particularly our care coordination support organizations, because there's a lot of culture change they have to do. And they're taking on a big chunk of work. So we had some ARPA funds that we have invested for initial operations. It was $14 million that we spread across the DSA for initial operating costs, and then also for them acting as a fiscal agent for the therapeutic and individual support services. The training that they receive, even the certifications that they receive in PracticeWise and those kind of things, it is all free to them. They send the staff to our training through the University of Illinois, and then those operating funds that we gave them are meant to offset the costs of having staff have to go to training before they can start doing billable services. So, again, we just want to make sure that, for once, we're actually supporting providers in that kind of area. Sorry, I'm talking bad about my own agency. I shouldn't do that. Okay, cost reviews the first 2 years to ensure that the rate is reasonably covering costs. Now, this is super important because this is a whole new world, right? I'm going to show you what the rates are, but this is a monthly rate per kid. We've not done this before. We modeled it on staffing levels and salaries that we think were quite generous. But we don't know if we got it right. We don't know. We could be paying them way too much. We could be paying way too little. And CCSOs were like, hey, we're taking on some financial risk here. I know you gave us operating funds, that's great, but what about the out years? So over the first 2 years of the program, we're going to be doing cost reviews. We haven't quite figured out the methodology that we're going to use yet, but we will get there. But basically, we want to mitigate any losses that CCSOs might incur, and then have a chance to recalibrate rates if we need to, kind of in a good faith arrangement with our partner providers, saying, look, you're gonna step out on this limb, and we're gonna be there to support you. So we're doing weekly CCSO office hours. Again, just trying to really maintain good communication, do a better change management approach than the state has done in the past. You know, where we're like, hey, here's your handbook, go do good work, right? We're trying to have a little bit more open communication about this particular one. And then ongoing training, mentoring, coaching, learning collaboratives, fidelity monitoring, right? Because while we want to support CCSOs, we also know that what the data has shown is that if you get to over 80% fidelity with the high fidelity wraparound model, you start to see those outcomes that we all want to see, right? Which is kids in school, kids at home, kids in the community, and kids thriving, right? I mean, we don't want to see them in hospitals and ERs and going to welfare and all that kind of stuff. We want to turn that on its head. And data has shown that if you do this right, that's what you start to see. So, lofty goals, and we're willing to pay for it. So I thought you all might be interested in seeing what the rates are, just in case you are, you know, potentially interested in funding some kids in your community that maybe are not Medicaid eligible for these types of services. Something to think about. If there's other supported services that you all are like, hey, we pay for this, and if we put it in with this package of services, we think it would be more robust and more helpful. I would love to talk to you all about that, because again, this is the beginning, it's building that infrastructure for a children's behavioral health system that I am hoping that more people will come to as we get it moving. We're willing to take the first steps, build the infrastructure, and we will hope that other people will come by. One more slide. Are you good with this?
Is it on the website?
Well, we will be posting rates, they're just not up there yet. They're embedded in our presentations right now.
We'll get a copy of the presentation.
Can I send it out? Absolutely, yeah.
Then we've got-
And there's no speaker list, so I'm not worried about that. It's all right, we'll get a PDF version to you, absolutely, yeah. Okay, now, we also have a dedicated email address. hfs.pathways@illinois.gov. So literally, if you're like, hey, what about blah? Send blah to that inbox and we'll get back to you. It is monitored, and we have pretty good response time for that. And then pathways.illinois.gov will give you all of the presentations that we have done so far, and it is many. It'll give you way more in-depth information about what we're doing with the care coordination and support organizations. It'll give you more information about the services that we talked about. What else do we have there? Oh, the RFQ that we used, if anybody's interested in that, is posted. Obviously, all the information about the DSAs. So, thank you so much for your attention. And yes, question. Yes.
For those two, remember the month, is there a commitment to, I know there's not a commitment to those grades, but is there a commitment to doing it? Long time?
Yeah, I mean, if this turns out, well, let me say this. Yes, as long as it turns out that it's the best way to fund.
It's working really well in others.
Yeah, exactly. Yeah, no, exactly. So if this turns out to be the funding mechanism that is most efficient for everyone and is meeting the needs of CCSOs and families, absolutely. Yeah.
How does this fit in with the goals of the consent decree?
Ah. Yeah, so the model that is required under the consent decree, this covers all of the components except for one. The only component that is not covered by this is the requirement that we do behavioral health screening within primary care.
Right.
So that's running on a different track. I actually met with the Primary Care Association yesterday to start that work. But, you know, the consent decree will require us to do standardized assessment, required us to do child and family TV. It required us to do tiered intensity of care coordination, required us to do more intensive home and community-based services. So we work with our national expert who's over the consent decree, telling us what to do, and he blessed us as checking off all those boxes.
Do they have numbers in the consent decree that you have to reach?
No, thank goodness they do not.
Not like getting so many kids out the list or whatever.
Right, no, what the consent decree did that I think is really fun is it stayed away from numbers. And it basically required us to build a behavioral health system for children that met the requirements of the consent decree, right? So, I'm sorry, go ahead.
Yeah, that's my question too. Is
Yeah.
what kind of training are, have they received, the MCR and the assessment folks regarding the IDD population?
Oh, okay, so IDD population. This program is really geared towards kids, that. How do I want to say this? That have mental illness, okay? Now, that does not mean that a child with severe autism may not meet the criteria, and if they do, they are entitled to all of these services. These services will have to be tweaked and probably more geared toward the family than toward that child, but we will be partnering with the DD system. I've got very strong partnerships with our division of developmental disabilities. I work with them almost daily, right? So they would definitely qualify for the care coordination. They would definitely qualify for any of the services. You'd probably be doing more family peer support for the family, and then again, connecting them, make sure that they're connected with the DB services.
So are the MCR and the assessment folks doing the work? Are they, have they been back to train?
So mobile crisis response folks probably could use a little more training in dealing with kids with severe developmental disabilities. It's an area that we struggle with for sure. And some of it is because connecting them to services is quite difficult right now. So yeah, that's definitely an area that we could improve. Did I totally answer your question, Ron?
Yeah, well, I had a good question.
You've been so good.
I look back.
Yeah, no worries.
That are already in the CFS system.
Yeah.
That was my question.
CFS programs.
That's a really good chance for that. Yeah.
There's children and family team meetings.
Yep. Yeah,
But
so
are they going to be fair, maybe a better quality? I don't know what time.
I've been working with DCFS on that wicked problem for about 2 years. And we, the thing that we have most concern about is making sure that the child and family team process is coordinated between what's going on in the welfare system and then what will be going on in the pathways program. So we're being really thoughtful and careful about that particular piece because you do not want two things. You do not want duplication and you do not want conflict between the care coordinator and the caseworker. So we're going to take a little bit more time to work through some of those details with DCFS. So I think their kids are going to come into this program probably a little bit later as we're kind of working out some of those nuts and bolts. So I'm working with DCFS, I mean, on just about a daily basis on just those particular issues. Yes.
So who establishes the list of diagnoses that meet the criteria for severe emotional disturbance? Is that done at a state or federal level? And has there been any conversation about how to create more inclusion for children that experience trauma-related disorders that don't meet the criteria for GCS?
Yeah, it's an interesting question, and I mean, we say that a kid has to have an SND diagnosis, and mostly it's because these kids come with, a list of diagnoses as long as your arm. But when we're looking at that decision support criteria, it focuses much less on the diagnosis and much more on the functional needs of the youth. So it's not a situation where I have a list of diagnoses, and if you don't meet one of these, I'm bouncing you out. It's more, we expect that there is a diagnosis, but we're really more focused on what are the needs of this child. So, traumatized kids can look like all kinds of different diagnoses. What the IMCANS helps us do is focus on ACEs, right? So it looks at those, and then adjustment to trauma, that's one of the major items, right? And that, actually, once we post the decision support criteria, you'll see prominently featured adjustment to trauma as one of the criteria that we look at for inclusion in this program. So I really appreciate the question and take what you said, really seriously, and we try to have that in our program. Yeah.
Follow
Try
up,
and true.
follow up on the DCFS.
Yeah, yeah.
I'm a veteran of the land wraparound system and was land 58 coordinator. And it was supposed to begin as a partnership between DMH, DCFS, and Illinois Board of Education. And when Jess McDonald was running DCFS, it's as if mental health and the Board of Education disappeared. And Jess McDonald was using the lands just to get kids off of the DCFS roles, like push them back into the community. We want them to return to the community. I remember Terry Slumka lecturing us on how the community created these kids and we're returning them back to the community. And I'm glad you're taking time with DCFS. Because they were really budget driven at that time.
Yeah. You mentioned some old school guys.
Yeah.
Came up under, yeah.
My screen should be a lot darker.
The CCSO and the DSA is really meant to sort of reinfuse that land approach, but bringing, Medicaid funding to support it. We would talk about sustainability, and that funding, I think, is really key to say we're anchoring this in this community. Now, come on, everybody, let's collaborate around it so that you don't have a situation where partners get, kind of pushed to the side.
Well, and they were numbers driven. We have so many kids in foster care, so many kids in out of state placements, so many kids here. How do we get them back into the community?
Their consent decree had numbers.
Yes.
So, we avoided that. But yeah, it's really important. And to DCFS's credit, they're trying really hard to keep kids out of DCFS just so they get services. And what I tell them is, look, Medicaid has to step up. It's time for us to step up because these are our kids too, and provide a better case of home and community-based services and care coordination to keep these kids at home so that they're not going into DCFS just to get those services. So, it's really incumbent upon us to step up and yeah.
So more of the rural communities, every effort made to have all of these services in their DSA.
Absolutely, yes. And there's situations where the CCSO may be the only game in town. And so what we're doing is working with those CCSOs to develop these other lines of service so that you have the full continuum, even if it's provided by one provider. Now, ideally, what I'd like to do is bring other providers to the area. I have some other ARPA funds. I have a $25 million bucket. And we're going to try to invest in some of those smaller providers that might want to go into a rural area and set up shop and start some of these additional services. Because there's service there, service deserts in the state that we really need to address. Interestingly, though, I found that in urban areas too, there's service deserts as well. So we've got a lot of work to do to make sure that we've got that full coverage. Other questions? I love questions, especially because you guys are pretty nice. My providers are really mean.
We're co-funders.
Exactly. Yeah, like common partners.
Online, to.
Oh, sure.
Okay, stop the screen share.
Questions for the other people too.
Yeah.
Yeah.
Oh, no, you're fine.
I'll just type back.
Just a question to ask. How is this approach going to differ than we do with choices?
How is this gonna differ from what we did with choices? Well. Choices was a little different on my side of the fence, I'll step up here. Because it was funded by DCFS at that point in time. And there wasn't really a clear delineation between casework and what choices was doing. And so we ended up, like I said earlier, in some of those terms. You know, and so you ended up with just a little more conflict in that particular project that I think was necessary. Interestingly, Medicaid funded a separate choices pilot that went a little bit better because it didn't have that sort of level of conflict. So I think what differentiation we have now is that it's Medicaid coming to the table saying, hey, this is a Medicaid covered service that we are offering to kids. You know, you all meet the criteria, it's a voluntary service. If you want it, great. If you don't, fine. If DCFS with choices, we mandated those kids in. And so it just created a little bit of a conflict-ridden kind of approach that we're not gonna have under the Pathways program. Does that make sense? And were you aware that
I know, no, you didn't explain.
Okay.
No, I was a part of that, and so that's why I was just trying to see what was different, just because there were a lot of families that were harmed when it just stopped, because they had a lot of supports and a lot of systems in place.
You know, what you just said hurts my heart every day. Every day, because that was a pilot. And it got going, and then the administration changed and the pilot stopped. Now, here's some comfort. The consent decree. We cannot just say, we don't want to do this anymore and pack up shop. This is, it's under a federal judge that says you will continue to do this. And what I truly believe is that even after we get out from under the consent decree, which is our goal, that this program is going to be so successful that the people will want to keep it, you know, that it won't be subject to, you know, budget cuts and all kinds of craziness that we have in administration. So we have sort of that foundation underneath us with the consent decree that I think is going to be really helpful in the rollout. But again, time. It's gonna take time for this to start really making an impact. 3 to 5 years. Who said, which one of you said 3 to 5 years? Aha, yes.
You said that, but I support this as well.
Yeah, the panel is in full consensus, 3 to 5 to 9 years. Right? So we've got to keep the faith. You know, you have to keep the faith as you're bringing these things up. It's not going to be fast enough. Not going to be fast enough.
Yeah, I just think it's interesting because I'm seeing this is like the third round of it, and I've been doing this work for about 12 years.
Yeah.
So
Yeah, I know, it's like here it comes in, right?
Yep.
That's what we needed. No, we really do. I'm not kidding.
yeah.
But appreciate that perspective because you know, families feel that too.
They do.
So let's go into Champaign and Danville and be like, we're here. And we'll be like, I don't know about you.
I used to do Unis family and child teams in the late 70s in the 5 areas of their life.
Yeah,
Met with them every day.
yeah.
I had a question for Dr. Summers. The blueprint, is the contact information and things like that for that, we're looking at doing a needs assessment. You mentioned blueprint, remember the logo up there, and I don't quite remember exactly what they did, but I wanted to find out more.
So Blueprints for Healthy Youth Development, that's what the website is called, which is operated by a different university. It is not a needs assessment. What it is tools to be able to kind of plug and chug different things that you're interested in addressing and you want to address them with. So if you already have that data, then that's your tool to find programs without having to, go through a Google search. You have an outside organization that looks at all that research out there for you. It tells you, it tells you what's gonna be the best fit. Now, the needs assessment component is something that I work on separately. I use, the baseline for the youth needs assessment I use is called the Youth Experience Survey. It's through the Social Development Research Group at the University of Washington, and it's something that I have access to from working with them previously before I came to SIU. And what's nice about that particular tool is it does kind of parse out different risk and protective factors. But it was originally designed to look at descriptively, to look at how the one community compares based on national standards. And I thought that it would be a better fit for the communities that I work with to take it a step deeper and see how those things relate. But there are other, needs assessments that I think you could use if you can be able to kind of parse out some of that same risk factor information. So do you have any kind of data on family conflict or on bullying or on substance use or on antisocial behavior? You can have data on those types of things, and it's very easy to be able to target, what kind of programs would be a good fit.
One of our high schools does an Illinois youth survey, another is just starting to promise to. Our data is kind of mixed in our area, and we used NIU the last time we did our needs assessment. Northern Illinois University, that's one of the closest ones, and a lot of the local governments in the western suburbs and stuff. We'll see. It's time for us to do one again, so I'm starting to collect.
Well, I should also point out another great thing about this website is that they not only give you information about mental and behavioral health programs, but they have been working the past few years to expand those options, different topics such as nutrition, and then programs, while they are originally intended just for youth, they're trying to think more at the family unit level, how to expand options.
We'll be getting, Nicole's PowerPoint this month.
Yeah, I can, it'd be better, I think, if I email it to you, so I can take off my speaker notes. I'm gonna please, I'll make sure, because I have some cards here, if somebody just kind of wants to talk about their community further, there's advice.
We would like to give our online members an opportunity to ask any questions. Anyone online?
No, they say don't go on. No, everybody's okay.
We're so tiny and next to the
Excellent presentations and information there. And we are close to the end of our section, I think, with our timeline. However, just if you can't answer it right now, be thinking again for the Children's Behavioral Health Committee, and again for your local communities from what you've heard today. I know you talked about graded funding and various things that mental health boards can in partnership. I know we fund Centerfield with our DSA, yes, and so we can look at how those funds are distributed and maybe work something with that. So again, if you have things from today's session that could be our agenda for ACMI's Children's Behavioral Committee, we want to hear that. So myself, or we've got other members in the committee here, let us know. It will help us with our agenda forthcoming. So thank you, everyone.
And the reception is next door starting at 5 o'clock. So it's just on the other side here. We'll be meeting with the hors d'oeuvres, so don't fill up on too much food before you come. Thank you.
Thank you.